Good morning, one and all, and welcome to all on this beautiful Sunday at Panchgani. Today's our first session. We will start. First, I will welcome Dr. Prajakta Purandare ma'am. She is MD Ops and Gynec, work as a lecturer in OBG in KM Hospital, and she is a past president of Baramati OBG department, Ops Gynec. Welcome, ma'am.
Good morning all. I welcome our next second chairperson, Dr. Navneet Desai ma'am. She is a consultant and director at Shobna Maternity Home and Jonah Hospital, Mira Road, and scientific secretary AFG Mumbai. Welcome ma'am. They don't have mic.
I request Dr. Navneet Desai ma'am to introduce our first speaker, ma'am, Dr. Anuja Kulkarni.
Hello.
So good morning, everyone. The first speaker for today is Dr. Anuja Kulkarni. She is a consultant obstetrician and gynecologist at Mamta Hospital, Latur. Her special interests are in laparoscopic and hysteroscopic surgeries. She has many papers and publications to her honor. I welcome you, madam. The topic she'll be talking on is lasers in hysteroscopic surgeries.
At the outset, I would like to thank Dr. Revati Rani and organizers of EVECON 2024 . Good morning, everybody. At the outset, I would like to thank Dr. Revati Rani and organizers of EVECON 2024 for inviting me to give a talk on role of lasers in hysteroscopic surgery. Actually, when I was told by Dr. Revati that the Indian Medical Association of AKLUJ is organizing this conference and dedicating it to lasers and to robotics, it was a surprise as well as a pleasure for me. And I thank the organizers for making me the opening batsman for this session. Use of lasers for hysteroscopic surgery is a topic very dear to my heart, and we are one of the pioneers with the use of laser in hysteroscopic surgery in India. Greetings from Mamta Hospital, Latur. As you all know, hysteroscopic surgery has evolved over the years, especially with the advent of newer technology and energy sources which have evolved. More and more conditions are being managed hysteroscopically than resolving to major surgeries like hysterectomy. The most commonly used energy sources in hysteroscopy are the electrical energy and the laser energy. It is very essential for the surgeons to know the basic physics, the applications, the limitations, the complications and potential hazards of all the energy sources that they are going to use. So lasers is the light amplification by the stimulated emission of radiation, a concept that was first put forward by Albert Einstein in 1917. For many years, laser was not being put into any application other than science fiction movies. In 1960, Maiman made the first working laser, and it was put into medical application in 1962. And it was first used by Goldrath for hysteroscopic surgeries. The first laser that was used was the ND-YAG laser. So what is laser? Laser is basically a monochromatic, coherent and collimated beam of light, which when it falls on the tissues, the tissue at the laser tissue interaction, there are various effects that are brought about. But for surgery, the effect that is used is the photothermal effect. Because of the resistance by the tissues get heated up by the lasers, and hence bring the coagulation and cutting effect of the tissues is brought about. The various lasers that are being used in hysteroscopic surgeries are the fiber optic lasers, which are the ND-YAG, the diode, the holmium YAG, KTP, and the thulium YAG. So these are the various publications with the use of the various lasers. Initially, ND-YAG laser was more commonly being used, and then presently the diode laser is more popularly being used by many surgeons from Spain and Italy. We have published our data with the use of holmium YAG laser for the surgery of hysteroscopic septal transection in 2021. Recently, our video article was accepted for publication by the American Journal of Minimal Invasive Gynecology. The various tissue effects that are brought about by the lasers, they vary with each laser because of its various characteristics. So, like ND-YAG has a more depth of tissue penetration as compared to holmium YAG. The various hysteroscopic laser procedures that are being done are the septal transection, the lateral metroplasty, intrauterine adhesiolysis, Asherman syndrome, polypectomy, and the others as well. So here I would like to show a video. This is Dr. Sergio's video, which shows the use of diode laser for incision of the uterine septum. Diode is a continuous wave laser with a tissue penetration of 0.5 to 1 millimeter. Since it is a continuous laser, there is a little bit of charring at the tissue interface. Holmium YAG laser is a solid state pulsed laser with a wavelength of 2100 nanometers, and it brings about various tissue effects can be brought about by holmium YAG laser, like the cutting, coagulation, vaporization, and ablation. And that is why it is known as the Swiss Army knife of lasers. It is widely being used in urology, orthopedic surgery, and dentistry. We have been using holmium YAG laser for hysteroscopic surgery at Mamta Hospital, Latur since 2004. The tissue penetration depth of holmium YAG laser as compared to all other energy sources appears to be least. It is just 0.4 millimeters of depth, and hence it is more precise. Holmium YAG laser brings about precise cutting on contact with the tissues. Defocusing of the beam or bringing it a little further away from the tissues can bring about coagulation effect, and it does not have any tissue effect if the laser tip of the laser is more than 5 millimeters away. We use a 2.9 millimeter Bitochi hysteroscope with the operative sheath and the 400 micron reusable quartz fiber, which is passed through this 5 French working channel. Hysteroscopic incision of uterine septum was the first surgery that we did at Mamta Hospital, Latur, using holmium YAG laser. Holmium YAG laser brings about precise cutting of the tissues, and quick. So even in broad septums, the surgery is finished quite fast. The vessels in the broad septum can be coagulated by defocusing of the beam. We start at the apex and go towards the base in a horizontal manner. We can also use this laser for cutting intrauterine adhesions in Asherman's syndrome. We have also used it in stage 2 and stage 3 disease. Dense adhesions can be cut with the lasers. Initially, the adhesions in the center are cut with the tip of the fiber, followed by the adhesions along the lateral uterine walls. Angulation of the long axis of the hysteroscopic assembly helps in the incision of the lateral tissues. The distending medium that we use along with lasers is normal saline. Fundal adhesions can be cut with the tip followed by these lateral adhesions. The tubal ostium was visualized after cutting the various adhesions. Since the tissue necrosis or the depth of tissue penetration or the depth of tissue destruction and the collateral damage is minimal with the use of lasers, the regeneration of the endometrium is also very fast. Vaporization of fibrotic bands can also be done with the lasers. Since Holmier-Mag laser is a pulsed laser, you can see that there is very little charring effect during the surgery. We keep an intrauterine Foley catheter after cutting these major adhesions. The second look hysteroscopy is usually done after 1 month of the primary surgery so as to rule out any recurrence of adhesions, and you can see over here that there are absolutely no adhesions. Dysmorphic and unicornate uterus is known to cause infertility and adverse reproductive outcomes. Fundal and lateral metroplasty has shown to improve the reproductive outcomes in these patients. Especially in T-shaped uterus, Y-shaped uterus, and also in unicornate uterus, it helps in widening of the uterine cavity and increasing the endometrial volume. So lateral metroplasty with the use of Holmier-Mag laser is also a very simple procedure which has shown to improve the reproductive outcomes in these patients. Endometrial polyps can be removed with lasers. Here, this is a postmenopausal woman with a stenosed external os. The os was incised on vaginoscopy, and you can see multiple uterine polyps, endometrial polyps, the pedicles of which are cut at the base with the use of this laser. Very small polyps can also be ablated or vaporized with the laser. Bleeding vessels can be coagulated by defocusing the beam. Hysteroscopic polypectomy in these patients can relieve the patients of their symptoms like postmenopausal bleeding and prevent them from undergoing major surgeries like hysterectomy. You can now see that there are no polyps inside the uterine cavity. These are the different hysteroscopic laser surgeries done at Mamta Hospital, Latur in the last 1 year. The advantages of lasers, as we have already seen, is that it is a precise and quick surgery with minimal depth of tissue destruction and lateral thermal damage. No cervical dilatation is needed as we are using the 5 millimeter operative sheath, and there is very little risk of fluid overload and hyponatremia because of the use of normal saline. It has a short learning curve due to its easy maneuverability. And since we are sharing the Holmi-Mag laser with the urology department, and since we are using the reusable quartz fiber, it proves to be very cost effective to us. So recurrent costs of scissors can be avoided if we are sharing this with the urology department. You need to know the precautions that are to be taken. That is the knowledge of the laser physics and its tissue effects. You have to always remember to put the generator on a standby when you're not using the lasers. Keep it away from the inflammables. See that the beam does not fall on any other inflammables, and use protective glassware if you are using lasers during laparoscopy. But since in hysteroscopic surgery, we are using it in closed environments, it is not really very necessary if you remember to put the generator on a standby before removing the assembly of the operative hysteroscope. So, as I always would like to say, that now we have to embrace technology, and we have to not keep any fears for the use of technology. In the older days, gynecologists, especially the lady gynecologists, used to be very shy with the use of technology. We hardly ever used even cautery for an LSCS. But I'm sure this is not the case nowadays. We have also seen how this machine can be made cost effective in our institution. Thank you so much for giving me an opportunity to present my work with this magic wand.
So thank you, ma'am. Okay. If anyone has any questions, you can ask. Madam is coming online. So lasers have changed the way we do our surgical procedures these days. And Dr. Anuja Madam has given a beautiful insight on the basics of laser and its role in hysteroscopy.
Till then, would you like to say something? We can have discussion. Yeah.
I actually had a question for Madam, but if she can answer, no, she has to connect for that. At the outset, I would like to thank the team of EVECON for inviting us as chairpersons. Thank you so much.
Thank you. We had a wonderful.
And it was really a very nice session. Since yesterday we are here, and all the lectures were superb, very well coordinated and well thought of. It is the need of the hour. So thank you so much. And even the cultural night last night was very nice, with the same theme continued. Very nice. Congratulations to the entire team. Anyone else has any experience with lasers, use of lasers in routine surgeries? They want to share their experience?
Madam just said that we should not have technology phobia, but
Yeah.
that is what we are facing right now, problems with the
Yes.
technology. So can we start with the second lecture that we have
Yes, yes.
recorded lecture, and
Yeah.
later on if both of them can join, so that we can take the questions together.
Right, right.
Yeah, thank you.
I request Dr. Prajakta Purandare ma'am to kindly introduce our second speaker, Dr. Vishwas Kulkarni sir.
Yes, thank you. Good morning and congratulations IMA AKLUJ for arranging this wonderful EVECON conference. As Madam has said, since yesterday we are enjoying the feast, academic feast of various innovative technologies in laser and robotics.
Dr. Revati Rane and organizers of EVECON for giving me this opportunity to be amongst you. I'm presenting this remotely because I'm in out.
Hello, I'd like to introduce Dr. Kulkarni. Good morning, sir. He is a practicing urologist since 1995 in Mamta Hospital, Latur. He has presented many papers and posters in various conferences at in India as well as out of India. For example, that means he had presented papers on sperm retrieval before TESE in University of London as well as in Birmingham. He was awarded many prizes for his best papers in Bhubaneswar and Massicon conference at Latur. He has participated in various regional, national fora, and he was a faculty and delegate in many conferences. Over to you, sir.
Good morning, dear friends and colleagues. At the outset, I would like to thank Dr. Revati Rane and organizers of EVECON for giving me this opportunity to be amongst you. I'm presenting this remotely because I'm in outside India for a conference. Lasers are not new to us. We doctors have been using lasers in different forms for the last 30 years. We all know this routine. The laser acronym is a light amplification stimulator for biostimulated emission of radiation. This was proposed by Einstein in early 1917 to be precise. But laser applications were not available almost up to 1960s. Initially, laser was an invention looking for an application. We did not know how to use it. It was majorly a part of fantasy for all of us, like Star Wars and Goldfinger, where powerful lasers were used as swords, they were used to cut people through half, but this was not possible then. Slowly we started finding uses of lasers, then we started having those small laser pointers, then CD-ROM device, then we had micro machining, like the way you put your names on small instruments. This was all done with laser etching. And now we started having different form of lasers which were for dermatological use, for surgical uses, for ophthalmic uses. But still, those powerful lasers cutting through people were not possible. But now with industrial lasers and with military applications, like you all must have heard about a large laser gun being deployed in Israel, which will work with the Iron Dome, where they can destroy incoming rockets and missiles by firing a strong, powerful laser beam on them. So we are now almost seeing the fantasies occurring in the amidst us. Now we have laser fibers which can be used through a hand instrument. It can be adapted to put use as a scalpel. It can be used through as a laser fiber. So why lasers and how do they help us? The lasers, because of the intense beam of a monochromatic light, cause water vaporization or a tissue vaporization, which leads to thermal effect. It can cut through the tissue, it can destroy the tissue, denaturate the proteins and cause hemostasis. Generally the water heats up and forms microbubbles, and these bubbles can burst and break a stone also. That's the mechanical effect. In photodynamics, whenever you fire a laser on a tissue, the light is reflected. And there will be a difference between a reflected light from a normal tissue or from a cancer tissue. So with specific lights which can be used to identify carcinoma in situ in bladder, where it is just a mucosal lesion and you may not be able to identify it with naked eye. Similarly, tissue welding is hypothesized. We have been trying to do a good tissue welding laser, but it is not possible. Still, it's a fantasy or impractical solution as of today. One of the many medical lasers which have come and gone, like CO2 lasers or pulse dye lasers, Nd:YAG laser was very common, but it had its side effects. Presently, holmium YAG lasers are most commonly used for soft tissues, for prostates, for stones. KTP green light laser is one laser which is absorbed by the tissue and it causes vaporization. So it has been used to vaporize large prostates where you can't cut them. Thulium laser and thulium fiber lasers are two different lasers, but which are also again very commonly used. Holmium laser is available since last 25 years. It has got a very specific wavelength which is absorbed by water and hence causes tissue damage which is predictable. It is carried through a flexible fiber and can be used through water. The many applications of laser are basically for stone fragmentation, for tissue cutting like posterior wall fulguration for strictures, or vaporizing or cutting large prostates also. The lasers are useful for urinary stones because the fibers are very small, 205 microns, 500 microns, 600 microns. Now there are fibers which are 100 microns, 150 microns. And these are very small footprint. And once the fiber, if it is passed through endoscope, can effectively work and same time will not obstruct the irrigation channel. All those who are doing endoscopy will understand importance of an open irrigation channel which will give a good water flow and a better vision. Also, because these are flexible fibers, they can be maneuvered, and as you can see here, the scope can bend into the lower calyx and break the stone there. Here I am showing a video to you which shows a lower calyceal stone. Excellent vision. The fiber is very small. You can see it's not even 1% of the total screen which you are seeing. So very small fiber, very effective. You go near the stone and fire, the stone starts breaking. This is a very hard stone, calcium oxalate. So there are more. It is better to fragment these stones and take out the tissue. But whenever you come across a calcium oxalate stone which is softer, you can just vaporize the stone, or it is called as dusting, and the dust will flow off. But whenever you come across a monohydrate stone, a dark black stone, it is better to fragment and pick up the stones and remove it and give a complete clearance. Here you can see almost the calyx is completely cleared, and in the opposite image you can see the fiber which is, so the laser scope which is completely bent almost 180 degrees and looking into the lower calyx. The second most common application which is unique for lasers is postourethral valves. As you all know, these are seen in newborn children, mostly diagnosed antenatally because of bilateral hydronephrosis and a distended bladder. And these patients develop severe renal dysfunction if they are untreated, and they can die in early childhood or even in their neonatal period because of renal failure, electrolyte dysfunctions, infections. So these babies are very small. The scopes which we use are very small, 6 French or 7.5 inch ultra thin cystoscope, out through which a fiber laser can go. So when we have fiber is used, power used is very low. So any 30-watt machine also can help. Here are two videos which show the posterior urethral walls. There are two different types. Type 1 is where there is an incomplete flip, I will say flap-like projections, and one on this side, actually, I don't know if you have missed it, is a complete occluding membrane. So this membrane can be fulgurated or vaporized with laser, while on this side, though it is taking a bit longer to show you, now here you can see the walls. And these walls are obstructive. Whenever the water comes in, it acts like a dampening, what we call it as a ball wall mechanism or an obstructing flap. This flap can be beautifully cut with a laser with minimal damage to surrounding tissues. And this gives complete resolution of walls, a good outflow. Again, this is a video of a same child, a similar type of patient. Again, the walls are being cut. While in this picture, this is post-op video. Now I'm coming back from the urethra, and you can see the walls are completely disappeared. So lasers are very precise. There is I won't go to this slide now because it just shows the post-op cystoscopy, and this is the urinary stream which we get immediately post-surgery or maybe 2-3 years down the line. Patients have a very good flow, the upper tract dilatation goes down. So lasers are really a boon for these kind of patients where the area is very small, the scope is very small, and you need a good material, a good source, energy source which can cut precisely. One of the biggest, what I will say is, problem or understanding of laser is we always consider laser as a powerful tool. But actually, it is a precise tool. A precise tool which has very low depth of penetration, causes minimum coagulation. So the tissue recovery is very good. Patients do very well post-operatively, and there is minimal lateral damage or minimal side effects. Prostate, as you know, is a big issue, or is one of the most common diseases occurring in men. And whenever you use a laser, I don't know if you can see my pointer here, the red thing marks the neurovascular bundle which is just outside the prostatic capsule. If you cut prostate with electrocautery, the depth of penetration hampers these nerves, and these nerves then get damaged. The patient can have post-operative incontinence, impotence. To avoid this damage, we can use lasers which have a minimal depth of penetration like 0.4 mm. Even the thermal damage is minimal, so you get a very clean cut. Now this on the right side is a animation, while the left side is actual case recording. The laser cuts very precisely with minimal lateral damage, and that is, I will again and again harp on it, that why we need lasers. I think I will just fast forward this because the animation is going faster than this. Once you cut the mucosa, a distinct plane between the prostate and its capsule is seen. Anatomically, there is always a plane between the adenomatous zone and the peripheral zone. So if you are between these planes, you can effectively nicely control the cut, and you can see the tissue which is remaining behind on the patient side. Don't look at the specimen side, look here. The floor is almost normal looking. It is not charred, it is not darkened, it is all white, as if you are peeling it off. That is what is happening in enucleation, you are peeling off the tissue. So these lasers have given a real I will say help to doctors, because it is done in normal saline. Once you do it in normal saline, issue of electrolyte disturbances, water intoxicity goes down. So there are no electrolyte imbalance. It can be done in normal saline. So even if some fluid is absorbed in the body, it is treated as if there is one more infusion going in. There is low charring, there is less edema, early catheter removal, you get a very clean tissue for histopathology. And on top of that, you need not stop the antiplatelets. Ecosprin now presently nobody advises you to stop. Clopidogrel is better stopped 3 days prior. But now there are many of my colleagues who are using lasers with dual antiplatelet going on.
Both our speakers are
Shall I
joining us
comment?
online. So if anybody has any question, please ask it.
Shall I comment?
Yes, yes, please, ma'am.
Yeah. Yeah, it was a very elaborative lecture on the use of laser in urology as well as gynecology. Dr. Kulkarni has elaborated the precise use of the laser technology in many surgeries, and as it is minimally invasive and the thermal damage is less, it must be causing very less post-op morbidity. The post-op stay will also be reduced, and it is a very good technology to for all these procedures. Thank you all the EVECON organizers for inviting us for this conference and making the chairperson. Thank you.
Thank you, ma'am. Unfortunately, there is some problem with the connection. So both the speakers are there online on the YouTube. So hopefully we can clear the doubts later. And we would like to felicitate them virtually also. Yeah, so.
I request Dr. Savita Gujar ma'am to kindly felicitate our chairperson, Dr. Navneet Desai ma'am and Dr. Purandare ma'am. I request our second session MOC to come on, Dr. Sid Madam and Dr. Khartare Madam.
Good morning, everyone. I am Dr. Trupti Seth.
Myself, Dr. Supriya.
We are moving on to our next session, that is lasers in ophthalmology by Dr. Sagar Vardhamane sir and lasers in aesthetics by Dr. Sharvari Pandit. I request Dr. S.N. Kulkarni sir to chair this session. Sir is very senior dermatologist in AKLUJ, practicing since 35 years, specialized in lasers and cosmetology. He is life member of Indian Association of Dermatologists.
I request Dr. Sanjay Purandare sir to chair this session. Sir is General and GI Surgeon at Rama Madhav Hospital, Vice President and Medical Director of Baramati Hospital. He is a past Vice President, IMA Maharashtra State, past Vice Chairman, AMS Maharashtra State, past President, IMA Baramati, and past CWC member. Sir is also past President, Medico Guild Baramati, past EC member, Pune District Badminton Association. Welcome, sir. Now I request Dr. Praveen Shinde sir to chair this session. He is a practicing neonatologist and pediatrician in AKLUJ since 15 years. Honorary Secretary, Academy of Pediatric, AKLUJ branch. He is an active IMA member and past CME Secretary of IMA AKLUJ.
I request Dr. Aditi Thite to chair this session. Dr. Aditi is practicing as dermatologist and cosmetologist in AKLUJ. She is clinical secretary at IMA AKLUJ, life member of Indian Association of Dermatology. She is secretary of Innovil Club of AKLUJ. Apart from her brilliance, she has keen interest in other fields also. She has won the title of Mrs. Beautiful at Mediqueen Maharashtra 2022, pursuing Visharad in Bharatnatyam. I request Dr. Praveen Shinde sir to introduce our first speaker, Dr. Sagar Vardhamane sir.
Good morning, everyone. So let's start with lasers in ophthalmology by Dr. Sagar Vardhamane sir. He is a practicing ophthalmologist in Vardhamane Eye Care Clinic, Pune. So let's start.
Good morning, everyone. Good morning, chairpersons. I would like to thank organizers of EVECON and IMA Women's Wing AKLUJ for this great opportunity. I'll start now. I'm not a good orator, so please pardon me. My topic is lasers in ophthalmology. Lasers are all about coherence of the light. So laser is acronym of light amplification by stimulated emission of radiation. History, we won't go in details of the history. Just first branch was the ophthalmology who introduced laser to the medical field. Meyer Shvikarat highlighted that photic burns may be beneficial as a therapy in the case of melanoma. That was the first laser used in ophthalmology. So physics, when electrons, metastable electrons, photon passes through these metastable electrons, then another photon is emitted. That is called as laser. Then there are three mechanisms of light emission: absorption of light, stimulated emission, spontaneous emission, and stimulated emission. Properties of laser light: monochromatism, emit only one wavelength; coherence, all in same phase, improve focusing; polarized, in one plane, easy to pass through media; collimated, in one direction and non-spreading; high energy, intensity measured by watt. What is the difference between laser and light? Stimulated emission, laser is stimulated emission and light is spontaneous emission. Laser is monochromatic, highly energized, parallelism is there, can be sharply focused. Classification of lasers. This is all physics you must have gone through since yesterday. These are various types of lasers. Laser variables are wavelength, spot size, power, and exposure time in ophthalmology. Tissue variables are transparency, pigmentation, and water content. There are three types of ocular pigments: hemoglobin, xanthophyll, and melanin. In eye, generally macular area has got xanthophyll, and retina, other retina has got melanin, retinal pigment epithelium, RP, and choroid. This is absorption spectrum in ocular tissues. We generally use argon blue, argon green, ND YAG, diode, krypton. Then there are three tissue effects: thermal effect, photochemical effect, and ionizing effect. With thermal effect, we do photocoagulation, photodisruption, and photovaporization. Photocoagulation is generally used in retina. Photodisruption in posterior capsular opacification after cataract. Photovaporization. Then photoablation, which is generally used in LASIK surgeries. Generally, in photocoagulation, denaturation of proteins happens. Photodisruption, tissue damage happens. And photovaporization is used as cauterization, incision, femtosecond laser, which is in thing now in cataract surgeries. Then there is photodynamic therapy. This is obsolete now with anti-vascular endothelial growth factor injections in the vitreous. These are delivery systems. We generally deliver laser by laser indirect ophthalmoscope or slit lamp, or in the surgery endophotocoagulation. Uses of lasers in ophthalmology are diagnostics and therapeutic. Diagnostic use are confocal scanning laser ophthalmoscope. Then this is in thing OCT. We generally nowadays use OCT, optical coherence tomography, to diagnose retinal pathologies. Then laser interferometry, laser retinal Doppler flowmetry. These are some indications. Then therapeutic uses of lasers: extraocular, removal of lid masses, orbitotomies, blepharoplasties, capillary hemangioma and Port-Weinstein trichiasis, periocular benign lesions, perioscular vascular skin lesions, conjunctival lesions. Then transcanalicular diode laser is now used as a replacement of conventional DCR for nasolacrimal duct obstruction. Lasers in anterior segment, cornea. These are all refractive surgeries. PRK, LASIK, LASIK. Nowadays, there is silk surgery and smile surgery. This all we do with excited dimer laser, excimer laser. Then femtosecond lasers, we generally cut the flap of the LASIK, and femtosecond lasers are used in cataract surgery also nowadays. With introduction of smile and silk, LASIK stays the mainstay of any corneal refractive surgery. Then iris and pupil lasers we use for pupilloplasty, photomydriasis, synecholysis, persistent fetal vasculature destruction, corticolysis, membranectomy. We don't go in the details. Now for glaucoma, for angle closure glaucoma, we generally do peripheral iridotomies, laser iridotomies. Then now cyclophotocoagulation transclerally. Then for lens, I have talked this. For posterior capsular opacification, we do ND-YAG laser capsulotomy. Then for fundus retina disorders, for mainstay of the treatment is for the diabetic retinopathy. There is hypoxia in the retina because of leakage and blockage of small arterioles. And to counter that hypoxia, we burn periphery of the retina so that macular portion gets the main blood supply. Then we use ND-YAG laser for prehyaloid hemorrhages. This is all theoretical things. In the surgery vitrectomy, we use endolasers, which delivers directly in the posterior segment. Then laser is used for retina or choroid tumors, like malignant melanoma, which was laser was first used for malignant melanoma in the history. Then retinoblastoma, retinal capillary hemangioma, pigmented lesions of retina and choroid accessible to OCT. This is pan-retinal photocoagulation, which is used for treatment of diabetic retinopathy. Neovascularization sets in after hypoxia. So to counter that, we do photocoagulation. For macular lesions, we do grid photocoagulation, focal or grid, which burns in the areas of the macula. But now this is also going obsolete because introduction of newer antivascular endothelial growth factor injections. Femtosecond laser is the in thing in ophthalmology right now. We can do various incisions, corneal incisions. Phaco-fragmentations means cataract fragmentation. Then this you all know, laser hazards. So laser is boon in ophthalmology right now. What is going on in USA is going on in India. So we must use all the lasers for to benefit human population. Thank you.
Anyone would like to ask or summarize the lecture? Any questions?
Yeah, thank you, Dr. Vardhamani, for an exciting lecture. We were knowing only about use of lasers in cornea and for cataracts, but you had given a beautiful overview of what all things can be managed by laser, right from extraocular pathologies right up to retina and from benign to malignant lesions. Thank you for an excellent overview of lasers in ophthalmology. And I would like to thank the organizers for giving us the opportunity to chair the session. And it has been an exciting conference. The contents and the lectures have been very good, and giving an overview of what lies in store for the future generations. And it is exciting to know that these things are really done in not only in mega cities, but of course in tier 2 cities as well. So thank you very much for everything.
Thank you, sir. I request Dr. Purandare, sir, to felicitate our speaker, Vardhamani, sir. Other chairperson, please kindly join the felicitation.
I request Dr. Aditi Thite to introduce our speaker, Dr. Sharvari Pandit.
Hello. Good morning all. Dr. Sharvari is a dermatologist and cosmetologist. She has a fellowship on dermatology, aesthetic and lasers and Arab Academy of Dermatology. She is a consultant at Pandit Skin Clinic and consultant at MMF Joshi Hospital and even consultant at Ramakrishna Mutt Hospital. Her special areas of interest are acne, anti-aging treatments which are non-invasive, aesthetic lasers, advanced peels and pigmentations. And she is a consulting trainer for Luminous India and Stellar Medical Agencies. And she has areas of training with aesthetic lasers, laser hair removal, HA fillers, Botox, threads, and non-invasive facelifts. So welcome, Dr. Sharvari. Over to you.
Good morning, everyone. So, lasers in aesthetics, skin aesthetics, do they really work? What do they do and what are the possibilities? I'll just go through very quickly. The laser applications, as you can see, skin rejuvenation. The major is laser hair reduction, pigment treatments, tattoo removal, and some vascular treatments can be done. People want freedom from unwanted hair. They want very soft, supple skin. Nowadays, having even little hair growth on the skin is not accepted by many. Lasers play a very big role here. People want spotless skin. They want even pigmentations and very uniform skin tones. Not entirely lasers will fix this completely, but it definitely helps. People don't want to age. They want wrinkle-free and younger appearing skin. So people want this. They want uniform, flawless skins. They don't want acne. They don't want scarring. They want absolute even skin texture. They do not want their pores on the skin to be seen. A lot of times, they are very bothered about the superficial vascularities that can be seen. So lasers can help you with all this. Can the lasers really deliver? So I will say sometimes they do. It's not absolute necessary that they'll do wonders, but there are some times that it really helps. So the most booming industry in the US and worldwide right now is the hair reduction industry. So the target chromophore is the melanin. Here you can see a patient. He was operated for a vaser liposuction. And after he got his 6 packs done with vaser liposuction, he still complained that he was looking like this. So we realized the problem was not with the surgery. So he just had to undergo a laser hair removal session. And this is how he looks. So the body contours, the skin, the inside muscle contours, the fat retentions, everything can be seen better if your skin is hair-free. Someone who suffers from this problem is definitely a candidate who should think of lasers. And a girl like her who will need to shave every day, it's very embarrassing. She will definitely be the candidate for laser. This is one of the most expensive laser hair removal platforms on the planet. It's called SplendorX. I don't have it, but it's my dream. So IPL Intense Pulse Light is not exactly a laser, it's a light, but it does a lot of good job like the laser. This is the NDAG hair removal system, a triple wavelength diode. This is my favorite, the luminous hair removal diode. This is one of the most popular hair removal systems on the planet. So a lot of males also seek these treatments. So it's not only females who are desiring a hair-free skin. There are a lot of males also who are really wanting not exactly hair-free, but a skin with less hair. So there are a lot of indications that males have. Like the male hair reduction requirements are very varying. One is laser beard shaping, hairline shaping. The male genitalia also they want to get treated. A lot of males have penile shaft hair and it's very irritating and troublesome. So they come for these treatments. The pilonidal sinus, the buttocks, clefts also can be treated. Earlobes, chest, back, arms, legs, almost every area of body can be treated with laser hair removal. Just a quick video. Sound nahi. काहीतरी चेंज करायला ठीक आहे मी एक्सप्लेन करेन नसेल होत नंतर झालं तर बरं आहे सॉरी द व्हिडिओ हॅज अ व्हॉइस ओव्हर आय जस्ट नीड टू प्ले इट याचं सेटिंग बदलायला लागेल का केला बघा बघा
This patient likes to keep a well-groomed beard and wants it low maintenance. We are doing laser beard shaping for him with diode laser. The area to be treated is marked at exact. Once removed, a certain hair might never grow back. Beard them meticulously. Mark both sides of the face and check for the symmetry. Shave the hair to be treated. This tip chills the epidermis on contact. It also emits pressure. This reduces chances of epidermal injury. Photons get concentrated in hair shaft and follicle, and the follicular regrowth ability is reduced. This is a high-speed handpiece of diode which is used for larger body areas. It is based on suction principle.
So here for this patient, the hairline reshaping.
Here is the patient 3 days later
and
with his
beard shaping.
desired beard shape.
परत व्हिडिओ होईल बघा आता स्लाइडच्या मध्ये होईल. Just a quick view of how the procedure happens. So full body treatment can take somewhere around 1 to 2 hours only. Some pre-post. Sorry. इथून करू का आता? फुल करा ना. इथे करू का स्लाइड शो? This is what you can really achieve, and in many cases. Great relief from facial hair. So IPL, intense pulse light. So it's not exactly a laser, but a great tool. It works similarly.
She is a patient of acne, showing acne at all stages of development. Intense pulse light handpiece of M22 has acne filter. It passes light of 600 to 800 nanometers. A large light guide is used for larger treatment areas. A smaller 6 mm tip can be used for single lesions. The IPL reduces signs of inflammation in the skin. This treatment is followed up by Acnelan treatment.
This is what you can achieve quickly.
These are the results after 3 sessions.
So a few pre-posts where I use similar treatments for these patients. So these are the possibilities, and I have seen that when the patient presents with a lot of acne, they're not like conscious about how they look. They dress up really bad. They don't care about how they are carrying themselves. Once their skin clears up, somehow it's a confidence booster, and I've seen them really dressing up well with a super confidence. It can also help with rosacea. A photofractional laser resurfacing is what we'll see now.
We combine erbium YAG laser treatment with Q-switched ND-YAG laser treatment for this patient with fine lines, wrinkles, and pigmentary problems. Resurfex is erbium YAG laser. It's a fractional non-ablative laser with minimal downtime. Shape, size, density, and energy all can be customized. Increasing energy increases the depth of penetration. It is a non-sequential scanning. The algorithm of scanner places each fractional spot in a controlled manner to protect tissue from heat accumulation and overheating. We combine the resurface treatment with Q-switched Nd:YAG laser treatment. The endpoint is faint erythema and sometimes visible villous hair bleaching. Multiple treatment sessions can be done, which are repeated every 3 to 4 weeks.
Here are some results that you can achieve with a fractional photofacial. You can see brightening of skin, and a nice skin glow is what the patients are wanting these days. The resurface, the erbium laser, can be used for treatment of scars. It's a little difficult to really see the scar on the cheek, but that patient was very bothered with even that tiny little scar on her cheek. So I treated it with erbium. It can be also used for burns. These are the kind of results that you can get with burn injuries and hypertrophic scars. It can be used for chickenpox scars as well. And it can be used in acne scarring. You must have heard about this carbon peel or carbon facial everywhere. We'll just see what it is. It is basically done for pigmentations and acne.
Here is a patient who wants quick lightening of acne mark, also wants treatment for dilated pores and wants a lighter skin tone. We are doing carbon peel for her. That was an activated carbon gel. The gel is applied as a very thin layer uniformly all over the area to be treated. The carbon particles are left on the skin for about 10 minutes. These carbon particles are hypothesized to absorb excessive sebum. Use metallic protective eye shields during the treatment. Then a Q-switched Nd:YAG laser is delivered to the area treated with carbon. The particles are heated up and are destroyed. Fume is generated. A smoke evacuator can be used. I'm using 5 mm diameter spot-sized handpiece for this treatment. The mechanism of action is related to peeling effect of the procedure. Thinning of stratum corneum, reduction of P. acne count, and decreased sebaceous gland function leads to reduced inflammation. The procedure is generally quite well tolerated. These are the results after 3 treatment sessions.
A few more results. This patient achieved this result in just 1 session. Another patient. So she was a patient of resistant acne, excoriations and post-inflammatory hyperpigmentation. She did not respond to any topicals or orals. So finally I decided to do a carbon peel for her. She really responded well. I wasn't expecting this. We'll just see quickly about the fractional radio frequency for rejuvenation. Again, it's not a laser, it's radio frequency, but works quite similarly.
She is a patient with signs of premature aging. She's just about 50 years with severe wrinkling, severe acne scars, deep nasolabial folds, and static forehead wrinkles. Anesthesia with infraorbital nerve block and infiltration anesthesia in the surrounding area is administered. We are using fractional radiofrequency technology called Morpheus 8 for this patient. The needles are insulated all through their length and deliver RF energy only at the uncoated tip. It cooks the tissue, causes a controlled thermal damage, and wound healing. These are the results after 2 sessions at monthly interval.
Last. Another application is tattoo removal. The long pulse NDI can be used for treatment of vascular lasers. I don't use it so much. Just one case I have to share. This was a case of port wine stain. She's still on treatment but responded after about 3 sessions. Thank you.
Thank you, Dr. Sharvari, for such an interesting and informative lecture. We have with us Dr. S.N. Kulkarni, sir, very senior dermatologist from AKLUJ. I request Dr. S.N. Kulkarni, sir, to share his experience regarding this.
Very nice lecture, Dr. Sharvari.
Thank you, sir.
I want to ask one question. What wavelength of erbium you use in this?
This is erbium fiber laser 1565.
1565. Okay. Is there any downtime?
About 2 to 3 days, but depends on the depth you are doing it at. So if you are at the depth of, say, the upper dermis, mid dermis, so about 40 joules plus energy, then it can get extended to about 4 days, 5 days. But a superficial treatment, 2 days is good enough.
Okay, and what wavelength of Q-switch you use? 1064?
Yeah.
1064. Yeah. With 1064 and which spot size and
so the
which
treatment,
mode?
for tattoo, I use somewhere around 2, 2.5, 3.5, depending on the density of pigment. And for the carbon, you can use 5, 6 plus till 8.
Okay.
So my machine has a spot size of 8. So the patient is not tolerating it where I go to 8. Otherwise, I prefer to do it at 5.
Okay. Nice, very nice, informative lecture, Dr. Sharvari.
Thank you, sir.
And
Hi. Very nice and informative lecture. Can it be used for keloid treatment also?
So there are a lot of reports now coming up, but it's tricky. So you have to tell the patient, if at all it works, it is good. If it doesn't work, you will have to maybe treat it with intralesional and add on with the laser treatment. So the resurfax I use for keloids, but I generally avoid the chest area. So something on the arms, back or face, I use it. But for chest, I don't, because I have not seen great results on the chest area. And you always have to combine it with intralesional injections. And the intralesional injections themselves give quite a good result. Yeah. So I first do the injections, and if anything is remaining, then I add on the laser. Otherwise, I don't.
Okay. Thank you.
Very nice informative lecture, Dr. Sharvari. I want to ask you one question. In hair removal, we use various types of platforms like IPL, NDAG. We are not using NDAG nowadays. Diode laser is we are using. But have you tried combined technique like IPL for some sessions and for some sessions you use diode lasers? Yes. And what is the end point of hair? Actually, it is not hair removal, it is hair reduction that we have to tell to the patient. But what is the end point of diode hair removal?
Yes, see, I'll tell you, you say sometimes that it is hair reduction, but I have seen patients responding so dramatically with the luminous diode, sometimes 2 to 3 sessions and the hair is gone. And I have patients who have been following up for 10 years, no single hair has grown up. So there are some patients who do not respond at all. There are some patients who respond really dramatically. Now there are some patients who are on like maybe the 25th or 30th treatment with me, they don't give results. So the hair has thinned down, especially on the face. So the thick hair is gone, it's very thin now, but it's not gone at all. So I have tried combining all the different modalities that I have. I have tried the YAG, I have tried YAG, diode, IPL separately. I've even tried stacking them. Like in one session, I've done IPL, then on top of that, I have done diode. Still there is no change. So if someone doesn't respond, he doesn't respond to anything. And if someone is responding, they anyways do good with any of the machines.
So no villous hairs at all. Even villous hairs are not there after the end point.
So in some cases,
Okay,
there are others who will have no response at all. So if what I have noticed is if the hair is too thick, then they respond dramatically well. Too thin hair, I'll prefer doing a Q-switch bleaching instead of doing a diode laser. But when the hair is midway, so it's not exactly very thin, like not villous, not terminal, the response is really pathetic. I tell them either you keep doing this, like how you go to your parlor, get your waxing done, you'll have to come here every 3 months and keep doing your sessions. As long as you want to keep the hair under control, or just tell them to shift to some other modality like shave, wax, or whatever they want.
Thank you.
Thank you.
What about white hairs? Sir is asking, what about white hairs?
Electrolysis. Sir, actually, we had a training about 1 week ago. There was a plastic surgeon who was telling us that when he's doing hair transplants, he had difficulty in picking up the hair when they were white. So they were trying to color the hair. So use a hair color for 3 consecutive days just before the transplant. So when they started extracting the hair roots, they saw that the hair root also changed the color. So now I am actually planning to start like a small study. I have 2 patients who have enrolled. So I'll be doing the hair color for them. So 3 consecutive days we'll be coloring their hair. And then on the 4th day, we are going to try doing the diode if it works. If that can be done, it will be great. But right now only electrolysis is what I'm doing.
Thank you, ma'am.
Thank you.
I request SN Kulkarni sir to felicitate our speaker, Sharvari Pandit ma'am. Other chairperson, please join the felicitation.
I request Dr. Nitin Ekatpure sir to felicitate our chairpersons.
For next session, I hand over mic to Dr. Gayatri, Dr. Nikhil.
Hello. Hello. Good morning, everyone. I Dr. Nikhil Ekatpure.
And myself, Dr. Gayatri Ekatpure. We will be beginning with the session 3. In this session, we have only 2 topics, and the timing will be 10 to 15 minutes. I request Dr. Bakulesh Mehta sir to chair this session. He's a past president IMA Maharashtra State. Dr. Bharat Pawar sir, he's a senior gynecologist from Mauritius and current president AKLUJ OBGY Society. And Dr. Nitin Rane sir, he's a physician and honorary secretary of IMA AKLUJ for past 3 years. I request Dr. Mangesh Darikar sir to deliver a talk on robotics in knee replacement surgeries, recent advances.
Hello.
I request Dr. Nitin Rane sir to kindly introduce the speaker, Dr. Mangesh Darikar sir.
Good morning, everyone. So we'll be going ahead with the lecture of Dr. Mangesh. He's a colleague and a dear friend of mine. He is a consultant robotic joint replacement and arthroscopic surgeon. He is a director, owner, chief robotic joint replacement surgeon at Darekar Super Speciality Hospital, Sinhagad. He's a consultant orthopedic surgeon and joint replacement surgeon at various other hospitals like Deccan Multispeciality, Hardikar Hospital, Apollo Spectra Hospital, Sahyadri. He has done his fellowship in arthroplasty and arthroscopy from St. Anna's Hospital, Herne in Germany. He has also done his fellowship in arthroplasty from Dinanath Mangeshkar Hospital. Actually, he has presented various platforms regarding robotics. He has his own robot and has wonderful set of patients which he has done. He comes to AKLUJ on a regular basis now for a visit purpose, and so we know him closely. He has seen many patients. Also, his special interest is in joint replacement and limb reconstruction, arthroscopy, and sports medicine. He is very much interested in sports, and we know that he has treated many sports individual personalities also with very good results. Over to you, Mangesh.
Thank you, Dr. Nitin. Thank you for the introduction, and I would like to thank all the faculty members and all the members of IMA for inviting me to deliver a presentation over here today. I'll not take a lot of much of your time because I know a lot of lectures are scheduled today. According to the introduction, I have been practicing since last 12 years in the field of orthopedics, joint replacement being my forte since last 10 years now. And I have conducted a lot of conventional orthopedic and joint replacement surgeries since last many years, robotics being the most keen interest of mine since last 2 years. Over the period of last 40-50 years, we have seen a lot of improvement in the field of joint replacement surgeries, where a lot of technology has been developed and adapted over a period of time with regards to robotics and navigation, and we are seeing a lot of improvement in the technology in the last 5 years or so. Where a lot of newer generation robotic technology is been adapted and used at various levels. And going briefly, robotics was introduced in the field of medicine in the year 1985, which was primarily used for neurosurgical biopsies which improved the precision for taking tissue biopsies, and which was later inculcated into neurosurgery department with transurethral resections in the year of 1991. Over the following 2 decades, we have seen a lot of improvement there, where a lot of newer systems like the Zeus and the Da Vinci platforms were developed, and they are still under development with a lot of advancement and being used across various surgical aspects of general surgery. However, orthopedics was lagging behind in terms of technology, where we had the navigation system, but we lacked the tools to execute the surgery properly without causing the human errors which are always associated with a lot of these surgeries. A lot of the surgical robots were dependent on robotically controlled arms. These were human controlled arms, and were utilizing 3D cameras and high definition cameras to assist the surgery, which was an added extension to the laparoscopic procedures which were carried out since last many years. Now we know for ourselves that a lot of platforms are now being used across India, where they are remotely operated, and surgeons are in complete control of those devices. Robotics in arthroplasty were under development since the year of 1980, and the first use of a robot with a tool was in the decade of 1980, which was used for knee replacement surgeries, which had a semi-navigation system and a electrical burr, which was directed on the basis of the anatomical landmarks which were registered on the system. So the orthodox system was the software for the Robodoc machine. Now, we know for sure that more than 2 lakh knees are being replaced every year in India, and it has been the most widely executed surgery across the country. The long-term survival rate of the implant and the patient functional outcome is the main, main motive behind the surgery, because a lot of patients coming to us are suffering with a debilitating pain since last many years, and they're not able to carry out their activities. They're pretty much housebound. So most of these patients, they come to us, and what they expect in return is that they should be comfortable and pain-free. However, what we have seen is that despite of carrying a precise surgery, a well-executed surgery which looks very good on X-rays, the patient still remains unhappy. They are still in pain. They are not able to carry out their activities many times, and that is a very daunting number of more than almost 20 to 30% patients turn out like that. Now, why was this seen? So here is an example of this. So this is a patient which came to me. I think we have operated her last week. She had an extensive varus because she had been carrying these knees for the last 15 or 20 years. She was hardly walking. She is a retired headmistress, and the thing was, we couldn't even fit her one single knee in a single frame. So we had to take 2 separate X-rays for both the legs. So extensive varus. If we had gone by the conventional method, then it would have been very difficult to balance this knee, very difficult to get the correct alignment visually. However, we did the robotic knee surgery, and we have got a very good result with respect to the alignment, the balancing. The patient was mobilized the next day, and the most important part being that she did not require any additional augment, because X-rays like these, they usually, when we do a conventional knee replacement, we take out usually more amount of bone, and soft tissue balancing is very less. And because the bone is taken out, we need added supports, augments in the form of rods, or sometimes some additional augmentation on each of the side. So we turned out to be sort of pretty much on the safer side, because we were helped by our robo, and during each and every step of the surgery we were able to assess what alignment was being obtained, how the balance would turn out to be after the surgery, whether the knee would remain lax after the surgery or not. So that was all predetermined. Now, conventional jig-based knee replacements, so they have their own issues. So usually what we do is we take a pre-operative X-ray film, and during the surgery we mark the anatomy and the landmarks, and we, depending upon which we place our jigs in a position which suits us the most and which is going to give you the proper alignment. Now, these are things which are surgeon controlled, and there are a lot of variables, and a lot of errors can happen if you do not have the proper orientation with respect to the anatomical landmarks, and you can always make errors in your judgment. So therein lies the problem, because a lot of issues arise if the implant is not properly positioned, or if the tissue tensioning is imbalanced. So if you have a tighter knee on the medial aspect, or a tighter knee in the flexion attitude, then obviously the patients, they turn out to be unhappy, because the knee themselves, they don't pain. The soft tissues which are there, the soft tissue envelope which has been stripped and which has been sort of realigned, it starts paining. Now, That is why the results are not reproducible each and every time, because yesterday we did almost 3 knees back to back with similar result in each of the patients. The x-rays, you can't even make out one from the other. They are almost identical. And I'll tell you that all the 3 patients had different preoperative x-rays. They had very different deformities, and one of them was an unstable knee. So at the end of the 3 surgeries, we were able to produce the similar results. All of them started walking in the evening yesterday itself. And what happens if you don't align the joint properly and if the ligament balancing is not proper? So the long-term survivorship of the implant is less than 7 years. So you'll get a patient back in your clinic in 7 years' time, and if it is not that optimal also, you can get them earlier. So implant loosening or implant failures, they tend to happen when a patient lands up for a revision surgery, and obviously they'll not be functionally at their optimum, and secondly they might have instability and poor functions. So this is an image of the Velis robotic system. This is the 4th generation robo, which utilizes a mobile robotic arm which gets attached. So it is a very small machine. So it attaches itself to the operating table, which makes our life much easier, because most of this older generation systems were quite bulky, and they almost take a place of 2 assistants, which sort of makes it very cumbersome for the surgeon to work properly throughout the to position himself according to his needs. So this is the graph which we see on the screen. So this sort of graphs we can take in sort of anywhere during the surgery. We can take a single cut and we can measure the graph. We can see how the tissues are balanced and how sort of the alignment is getting corrected. Now, there are a few basic concepts with regards to orthopedic robotic systems are that there are mainly generally 2 categories, one being the imageless system and now the other being the imagery system based on CT scans. So we have an imageless system, so we are not very dependent on a CT scan, and we are not just addressing the bony landmarks, because CT scan, as we know, is just going to represent the bony landmarks, and depending upon that, the surgical planning is done in those older generation robotic systems. In newer generation, we take into consideration the soft tissue balancing, which can get altered during the course of surgery as and when we take the cuts. So it sort of, the initial planning and the final outcome usually changes when the surgery is going on. Now, yeah, so the advantage of the 4th generation system is that it is an imageless system, so no preoperative CT scan is required. Only conventional X-rays are sufficient enough. We don't even need a scanogram, which is a full-length hip, knee, ankle X-ray. And surgical planning is done during the surgery, and we can make alterations to our plan at any given moment of time. It's a navigation based system, so yeah, so a lot of things can be adjusted accordingly. It is minimally invasive, and in conclusion, we have seen improved patient scores. The patient is able to bend their knees actively within a few hours once the spinal wears off, and we are able to see patients who can walk in 2 hours of surgery, and they're able to go to the toilet with the walker. They don't need an assistant, and they go by themselves to the toilet, which we did not see when we did conventional knees, because patients were not able to bend their knees actively. So the functional scores are pretty good, and we have predictable outcomes, because most of the times the patients behave in an identical manner. We have not seen many aberrations there. The X-rays are pretty similar, as I said. And we get out with a sort of a good soft tissue envelope because we require minimal dissection and meager blood loss. So we up till now, we have done more than 50 robotic knees since we have installed this system at my place in the month of January. So we haven't had a single patient we needed to transfuse, even if we did 2 knees. And the reduced pain scores reflect in the form of the medication part being very less. The patient is managed on just 650 milligrams of paracetamol given 4 times in a day, and sometimes an oral tramadol is required. So we don't even require injectables now. So patient is pretty well managed for the first 24 hours with an injectable cocktail which is given inside the knee, and the second day the patient is shifted on oral medication. So we are completely off diclofenacs and all, so we don't require that. So I would like to share some images and a short video if you're interested. So the So the patient which I showed the x-rays previously, the full length x-ray which we got corrected, this is her knee. So pre-operatively when we opened up, this was the instability which was there. It was grossly lax. Oops. Walking. This was the pre-operative gait. This is second day of surgery. So I've got full correction, if you can see. She's walking well now. We haven't removed her stitches yet. And this is how it looked when the entire deformity was corrected. And here is a glimpse of how the robotic system looks like. So it is a hand-based saw system. So the cuts are pretty precise, as in we can alter the cuts in millimeters. So even if you require just a 2 millimeter cut, the robo can adjust itself and it aligns itself to the plane of the cut, and I just have to press the button and it does the rest. The most important thing being it is a semi-autonomous system, because we have autonomous systems right now, but I did not go for it by purpose, because even if you make a margin of error while registering the landmarks, the robo can offshoot of the bone, and it doesn't have a haptic feedback, so it does not stop at the soft tissue. So there have been incidences where there have been vascular injuries. So this being a completely haptic controlled and a sort of a surgeon controlled device, you'll always have the feel that you're in control. So the arrays are these are the arrays which you can see on the femur and the tibia. These are the sensors which are picked up by the high-speed cameras. They are constantly in touch with the camera system, and the saw works if and only if these things are visible. So this is how the cuts are executed, and I have a video. I'm done. Video. Yeah, so we can see that the robo aligns itself, and we have to dismount it from the machine. And once it gets aligned, you just have to press the button and take the cut. So it's hardly a 7-minute job, which used to take me almost half an hour. The cuts can be executed in a single go. We don't require any additional jig or any additional instrument to check that. And all cuts can be verified with the robo. whether we are in the given limits. Okay. So with this video, I'd like to conclude my presentation.
Thank you, Mangesh. Thank you for an excellent presentation. Thank you for enlightening us about these new things. There are many myths still about the knee surgeries, and so robotics coming up and the technological improvements that have been there. It would be very useful. We need to educate the people, also the doctors, regarding these new improvements. Also, you gave us the gist about conventional jig-based approach versus the newer types, and the recent advances pertaining to the 4th generation imageless systems and the usefulness of it, and obviously the smooth post-op recovery. So obviously this is a boon to our patients who suffer from these knee problems.
These guys are coming up with the hip module also now.
Okay.
So we have got Unicondylar, which will be launching in the month of probably June or July. And Unicondylars, they have their own indications. And once the hip comes, this machine will be a great asset to our area.
Okay, thank you. In view of time constraints, we won't be taking any questions. If there are any questions, he will be happy to answer in the audience. Thank you.
Thank you.
I request Dr. Bharat Pawar sir to felicitate our speaker. I request Nitinani sir to join the felicitation. I request Dr. Sanjay Deshpande sir to deliver a talk on digisexuality.
Hello. Good morning, everybody. Our next speaker is Dr. Sanjay Deshpande sir. He will be speaking on digisexuality. Dr. Deshpande is past chairperson of Council of Sex Education and Parenthood International. He is Assistant Secretary AOFS, Honorary Secretary Indian Andropause Society. He is past President IMA Maharashtra State, past President Indian Medical Association Nagpur. He has many awards. He has been recipient of Golden Lamp Award CSEPI, Best Honorary Secretary and President of IMA and State at national level. Sunrise Peace Mission Yogi Manohar Vaidyakiya Seva Ratna Puraskar. The mic is over to you, Dr. Deshpande.
Thank you, dear chairpersons. In fact, I must thank Dr. Santosh Khadtare for allowing me to be here, rescheduling my lecture, which was supposed to be on yesterday because of some emergency situations. So thank you, Santosh. The first disclaimer before I start my topic is that previous speakers have spoken on their personal experiences with robots. I have nothing personal experience about this digisexuality. So that is first disclaimer. Friends, our life has become complex nowadays. Previously it was only the man and the animals, but now the man, animal and machines all are together living in this world, and we have to adjust with them. And many aspects of our lives are being transformed by technology, including how we feel and express our sexuality. Because sex is not only the peno-vaginal intercourse or the vaginal intercourse. It's a union of two souls. I always remember our very senior sexologist, who's no more now, Dr. Vittal Prabhu. He used to say that sexual intercourse is not only maithun. Marathit दोन शब्द है, maithun आणि संभोग. So what maithun is sexual intercourse. When penis goes inside the vagina, it can be called as maithun. But sambhog is even more than that. It is not only physical, but it is mental as well as spiritual intercourse. Samabhog. Both the partners should enjoy simultaneously in an equal fashion. So that is samabhog. दोघांनी सम असा भोगायला हवा असा तो अनुभव त्याला आपण संभोग म्हणतो. But because of nowadays many advances in technology, the worst advantage or the worst disadvantage I can say is because of machine is that we are losing contacts with each other. But nowadays it has become a necessity also. And that's why we have to think and discuss about this digisexuality. It may not be a reality right now, or maybe very exceptional human beings are using this, not only in India but in Western world also. But definitely it can come in a big way. Now we can instantly talk with our lovers, our intimate partners. Gone are the days when husband used to be away from the wife and then he used to come only once in a year or so and have the sexual relationship. Nowadays, even video chats and everything is available. So these are all modes of telesex communication. How purposefully included sex sculptures in this, because that is what ancient India has. We have our speciality. When the whole world were not discussing anything about sexuality, our temples and our caves were having the good depiction of sex and sex cultures. WhatsApp, very important and very useful tool nowadays for two lovers interacting with each other, either by texting or by video calls, sex chats, sex toys, and sex dolls. So these are all what used to be or what is being used till now or in current situations, except the sex robots. Now it started in 16th century when some sailors from France and Japan, they started preparing the masturbation puppets, because these sailors used to go for months or years together away from their families. So the sex doll was the first sex doll was prepared by these sailors with just some cloths, leathers. Then in 1968, the first doll was prepared. It was an inflatable doll and was advertised in pornographic magazines. The sex dolls were inflatable with air consisting of penetration areas as mouth, vagina or anus. However, due to their inflatable nature, they used to get spoiled very early. So then the material means this advancement start taking place, and then latex and silicone were used, and then full-fledged, realistic, posable and life-size sex dolls were marketed in the world. Of course, mostly in the US and other Western world. And in 2009, they started using platinum-cured material instead of tin-cured silicone to further enhance the durability and lifelike nature of the doll. So the nature of the doll nowadays is like a real human being. And if added with artificial intelligence, then it becomes a robot. It is estimated that in 2050, just around 26 years after, it will be perfectly normal for women and men to experience love and sex with robots. This futurologist Ian Pearson, he predicted that by 2050, women and men will have more sex with robots than with their spouses or partners. So what were the sex toys? Sex toys first came, then sex dolls, and then sex robots. These are nothing but the human body parts, mostly dildos, which we know that penis-shaped, and vibrators. Vaginas are also there. They are widely used and normalized. The lifetime prevalence of vibrator use, for example, is approximately 50% in the heterosexual in United States. In the digital age, sex toys are becoming increasingly technologically advanced. Vibrators having integrated cameras now available that can be remotely controlled by a partner in a long-distance sexual relationship. Because long-distance sexual relationships have become a norm now. Husband is in India, wife is at some another place in United States or in Europe, or husband is in Europe or United States and wife is in India. Or even in India, they are far away from each other. And because of that, these new inventions are taking place. Only one thing is that use of sex toys is illegal in India. There is one law that they says that use is not illegal, but sale of sex toys is illegal in India. The law is sale is illegal. This Ambrosio YB, a so-called bionic dildo, which provides haptic biofeedback while strapped. So person can experience some erotic feelings while using this. This haptic way is that they stimulate the muscle as well as the nerves endings through electrical stimuli. These are sex dolls, just like human beings. They look like human beings. Anatomically correct anthropometric dolls of different. Usually, the thought process started by seeing the mannequins which we used for CPR and other things. The scientists started thinking on that line and then made the human-looking sex dolls. They are called as love dolls nowadays. People don't want to say sex dolls, so they call love dolls. And they say that it is not only for the sex purpose, but being as a companion, also they are used. They come in different genders, races, ages, body types, customized. Abstract sex dolls have no resemblance with any real person. But the portrait sex dolls they are designed like a real person. A person can get it customizedly prepared, either by the face of a porn star, celebrity, or ex-partner, or a current partner, or whatever it may be. So this is nothing but what my topic is, why we called it digisexuality. The sex robots are used, and the use of sex robots in sexual life is called as digisexual, and that's why I named it as a digisexuality. So males robots are called as male bots or man bots, and females are called as femme bots or chick bots. Gender neutral terms are also used. They are called as sex droid or pleasure bot. So these are various types of sex doll, hyper realistic sex dolls. There are several companies that create silicone sex dolls that both look and feel like real people. They offer customers diverse customization options, including hair color, nipple style, body shape, makeup styles. One of the most popular is Abyss Creations in the United States, which makes the real doll that is also developing a talking robot. Japanese companies also rival in this realism, as their culture has strong appreciation for dolls. Chatbots, many of us know it. Humanoid robots. This was one of my part of my presentation where I talked on future of sex in future, what sex will be. That future of sex can be remote intimacy, internet connected sex toys, teledildonics, long distance kissing devices, VR haptic body suits, and connected pillows. So person can listen to the heartbeats and everything at a distant level, so that just a partner is present there, he or she can feel the presence of the partner. Remote sex is a sex between two or more people who are not in the same place, yet are connected through the internet. People often use electronic sex toys operated by computers or devices that use data to boost the experience and share the pleasure. They transmit the sensation through touch sensors to help long-distance partners arouse each other. That is what is haptic. Super-connected sex toys, interactive sex shows, participatory porn. We are discussing about effects and side effects and bad effects of pornography. But participatory porn is also nowadays maybe a future, that one can participate in sexual activity, at least on the screen, and experience that through the haptic ways. Teledildonic virtual sex words, computer-generated words, and massively multiplayer online sex games are beginning to support remote sex devices. So when the avatars are having sex, the people behind the computer can feel the action through the synchronized sex toys. Long-distance sex, pansexual social networks, remote sex workers, even commercial sex workers also can have the clients from the long distance. Now these sex dolls or sex robots, it's not very, very easy and cheap source of sexual gratification. So people have brothels also. Means in United States, they have brothel also but then later on it was stopped because of the anti-movement by the residents and public. Holograph, we know holograms and everything, people used to do it for canvassing in Lok Sabha elections last year. But these holograms also can be used nowadays for making love with the distant partner. Virtual sex through telecommunication, seductive artificial intelligence, creating the atmosphere, immersive environment. Just as we see in Singapore and everywhere, the 3D or 5D environment, and we experience the same feelings. Same thing is with this immersive entertainment, multi-sensory experiences, blended sexual environments. This very, very long list. I'm not going into the details of it. Wearable sex performance. Now, what is the use of these sex dolls? Because if there is a market, there are users. And if there are users, means there must be some uses. Maybe one may like or not. So it is a recreational and long-term use at home. Those who can afford can buy this. Social companionship, sexual exploration, pleasure, increased satisfaction. Disadvantage means strong negative effect in terms of objectification and violence against women. Because of this very wide use of pornography, the violence against women has increased. People see that women is just a tool of sexual gratification. And that is wrong. There are many gender scientists, they feel that if it starts very much in the society, then people will feel that this is only female body, not a soul, and that all the problems will arise out of it. Even adolescent girls, women, because of the mass media nowadays, everybody wants to look beautiful. And if these sex toys and sex robots are so beautiful and perfectly having a perfect figure, then its impact on the adolescent girls and young women will be very large. So that will also have adverse effect. So are these only selecting one gender? Are these sex toys? Previously what used to happen, sex toys were only for women, like dildos and vibrators. But now because of shift of sex dolls and sex robots, now the shift is only for the men. So there may be chances that robotic males, robo males also will be used. And I always say that in our ancient history, somebody say it mythology, but I say it ancient history. आपल्या पुराणातल्या गोष्टी जर आपण ऐकल्या, so what we know that Shankar has given a birth to Kartikeya without any help from Parvati. Or Parvati also gave birth to Lord Ganesha without any help from Shankar किंवा महादेव. कदाचित तसंच पिक्चर पुढचे काही दिवसानंतर पाहायला मिळू शकते. A man will not need a woman or a woman may not need a man. Do we want such atmosphere or life in future that we have to answer it? So commercial use, everything. There are some therapeutic uses. I just will tell one. That people say that like in sex therapy, sex counseling, we can use it because there will be a partner-like situation and there will not be a huge performance pressure. So person can have a good sexual excitement as well as the treatment for erectile dysfunction or other sexual dysfunction can be very well be done because of that. Or body therapists, sex therapists also can use this. There were questions from even sex workers also that we will be extinct from the society because the role of prostitutes will be taken by sex dolls or sex robo. So will that be a future? So there are many questions, but the claim benefits are that they can be used as surrogates, body therapists, or they can be used in sex therapy for having a good result. But the question is that will that be a boon or curse? I left the answer. I wish that you answer it yourself. Thank you very much.
Thank you, sir.
Thank you, sir. It was an elaborative lecture and it showed how modern science has helped in this field, right from sculptures to love robots. But what I feel, as you initially mentioned, it will be only Maithun with a robot, and the sambhog will be only with a live female only, sir. Thank you, sir.
So live partner with in live situation is more important. Thank you.
I request Dr. Nitin Rani sir to felicitate our speaker, Dr. Sanjay Deshpande sir. Also Bharat sir to join the felicitation.
I request Dr. Suryanshi sir to felicitate our chairpersons. After this, we'll proceed for the important function of the day, inauguration.
I would like to make one important announcement. The checkout time for rooms is 12 o'clock. So I would request everyone to please check out the rooms and hand over the luggage at the concierge at the reception desk. Thank you.
To conduct inauguration, I request Dr. Padmaja and Pradnya to please come forward and take the charge.
केबल काढ दे केबल काढली का केबल काढायचं कुठला
We'll be going ahead with the ceremony. In just 5 minutes, we have a small tea break. If you are interested, we can have a tea and meet again in 10 minutes. Don't leave the hall. Please be present for the function. The inauguration program will start in just 5 minutes. We have got a tea break. If you can have tea and come back.
Good morning, everyone and all. I would like to welcome you all on this lovely morning on behalf of IMA AKLUJ. It's an honor to stand before you all and to welcome our esteemed IMA leaders on the occasion of 14th Indian Medical Association Maharashtra State Women Doctors Wing Conference EVECON 2024, hosted by Indian Medical Association AKLUJ GENEXT 2024 on 4th and 5th May in the beauty of Panchgani. We embark on this journey of knowledge, sharing for excellence in our practice and for the better service of our patients. So, we must embrace the innovations and the new technologies like lasers and robotics to improve and evolve as professionals. Let's rededicate ourselves to the pursuit of knowledge and the advancement in this medical science for the betterment of our patients. These 2 days, we had a wonderful academic feast covering the use of lasers and robotics in all the fields of medicine: the dermat, ophthal, gynec, onco, surgery, fetal, and general medicine. We have received an overwhelmed response from all IMA doctors all over the Maharashtra. Now, friends, we will proceed to the most important and the most awaited part, the inaugural function of this conference. I welcome all the esteemed IMA leaders on behalf of IMA AKLUJ once again. Now I request Dr. Khadtare sir to kindly escort the chief guest of today's ceremony, Dr. Shivkumar Uttare sir, National Vice President, IMA Headquarters, New Delhi, and past Maharashtra Medical Council President, IMA Maharashtra, onto the stage. Now I request Dr. Sanjay Seth sir to kindly escort President Dr. Dinesh Thakre sir, President, IMA Maharashtra State. I request Dr. Nikhil sir to kindly escort guest of honor Dr. Ravi Panchgani sir, past President, IMA Headquarters, New Delhi. Now, I request Dr. Nitin Rane sir to kindly escort Dr. Jayesh Lele sir, past Vice President, IMA Headquarters, New Delhi. I request Dr. Amol Shinde sir to kindly escort Dr. Anil Pachnekar sir, National Vice President, Aao Gaon Chale Project. I request Dr. Aniket Inanda sir to kindly escort Dr. Jayant Navrange sir, past Chairman, Social Security Scheme, IMA Maharashtra State. I request Dr. Rohit Pade to kindly escort Dr. Vikrant Desai sir, Treasurer, IMA Maharashtra State. I request Dr. Guzar ma'am to kindly escort Dr. Meena Vankhedkar ma'am, past President, Women's Doctors Wing, IMA Headquarters, Delhi. It is indeed a great fortune for us to conduct this ceremony in the esteemed presence of Dr. Ram Arankar sir. I request Dr. Khadtare sir to kindly escort Dr. Ram Arankar sir, past President, IMA Maharashtra State. I request Dr. Sanjay Seth sir to kindly escort Dr. Bakulesh Mehta sir, past President, IMA Maharashtra. I request Dr. Nitin Rane sir to kindly escort Dr. Nitin Godpare sir, Vice President, IMA Maharashtra. I request Dr. Khadtare ma'am to kindly escort Dr. Asha Jadhav ma'am, Joint Secretary, IMA Maharashtra State. I request Dr. Digvijay Rao to kindly escort Dr. Yashwant Gade sir, Chairman Aao Gaon Chale, IMA. I request Dr. Rohit Pade sir to kindly escort Dr. Prakash Marathe sir, past President, IMA Pune, Honorary Secretary, Social Security Scheme, IMA Maharashtra. of IMA AKLUJ. I request Dr. Nikhil Mishra, Treasurer IMA AKLUJ, to kindly join the dignitaries on Now, the most awaited person, not last but the least, Dr. Reti Rani, Chairman, Women's Doctors League, IMA Maharashtra, and the organizing chamber and the backbone of today's conference, EVECON 2024.
Stand up for the IMA prayer. Please repeat after me. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure.
Now we'll proceed with the flag salutation. Please do not repeat. We, the members of Indian Medical Association, stand before here to salute our national flag. It's an honor and a glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA. I request all the dignitaries on the stage kindly proceed for the lamp lighting ceremony.
would request Dr. Revati Rane to kindly take us through this journey of EVECON in a few words.
Hello. Respected dignitaries on dais, all the delegates who have joined here, online and offline, faculty members, my friends and colleagues. On behalf of IMA Women Doctors Wing Maharashtra State and IMA AKLUJ, I welcome you all for this official inauguration of 14th Maharashtra State WDW Conference, EVECON. I must say that on the 23rd February, I got to know that I have been appointed as a chairman of WDW. And I have to confess that it was out of the blue and I wasn't very much ready for that because I knew it is a mammoth task of arranging EVECON and taking the responsibility of being a chairperson or chairman of the whole Women Doctors Wing. Because you have to lead the women who are already empowered and who are already strong and be the light holder for them. So in that 2 months, we did Life Beyond Medicine 2 episodes, which also got good response. And we had this task of arranging EVECON. It wouldn't have been possible in just 2 months without the active participation of IMA AKLUJ. I must say to everyone that we are a very small society, but we are united and we have so much strength within us that everyone has worked beyond and the scope as his or own post and has done work for many. So the great round of applause to the whole IMA AKLUJ. I wouldn't say just the committee, the IMA AKLUJ, and the supporters, even the supporters behind that, because even the non-IMA members here, the spouses, they have been so supporting that everyone can put in efforts and work for that. The theme we chose for this was robotics and laser, which was really little bit difficult because to find the speakers for that within that short period of time was difficult. But we could manage, and I'm very happy that everyone has given the inputs that they like the content of the conference. The scientific content was very good, and even we could, able to reflect that in the banquet and the cultural theme. Everyone was surprised, robotic dance ka asto kiva laser dance, but we could see yesterday that everyone can do robotic dance. We might learn robotic and laser later on in our practice, but robotic dance everyone can do now. So here we are celebrating this wonderful conference, and everyone has traveled here from all the places from Maharashtra. So I really thank you all for that, and thank you once again. Thank you.
Thank you, Revati. Now I ask Dr. Santosh Khadtare sir to kindly welcome all the IMA dignitaries.
सर्वांना नमस्कार. आज इंडियन मेडिकल असोसिएशन महाराष्ट्र स्टेट वुमन डॉक्टर विंग कॉन्फरन्स या ठिकाणी साजरी करत असताना या उद्घाटन सोहळ्याचे प्रमुख या ठिकाणी आपल्याला चीफ गेस्ट म्हणून लाभलेले IMA नॅशनल हेडक्वार्टरचे व्हाईस प्रेसिडेंट, महाराष्ट्र मेडिकल काउन्सिलचे माजी अध्यक्ष आदरणीय डॉक्टर शिवकुमार उत्तुरे सर, या ठिकाणी अध्यक्ष म्हणून आपल्याला लाभलेले इंडियन मेडिकल असोसिएशन महाराष्ट्र स्टेटचे कर्तबगार आणि अतिशय सिन्सिअर व्यक्तिमत्व डॉक्टर दिनेश ठाकरे सर, गेस्ट ऑफ ऑनर म्हणून या ठिकाणी आपण ज्यांना आमंत्रित केलेले आहे असे पास्ट नॅशनल प्रेसिडेंट, पास्ट ट्रेझरर वर्ल्ड मेडिकल असोसिएशन, पास्ट प्रेसिडेंट सार्क मेडिकल असोसिएशन, पास्ट वुमन डॉक्टर विंग for me, madam. Past Vice President, I am a national. आपल्या सर्वांना माहित आहे की कामदेवबाबांना ज्यांनी उघड विरोध केला, त्यांच्या विरोधात टाकली ती केस जिंकली डॉक्टर जयेश लेले सर.
My younger brother, the bestie of Navneet, is from Mira Bhainder, is now treasurer of the IMA Maharashtra. Very dynamic in the AMC also. He has represented very well, knowledgeable, well versed about physical fitness and all. But yesterday I have seen his singing class and all, and I really appreciate, admire from bottom of my heart. So thank you very much, boss. Our Bishop Pitama of the IMA, Dr. Ram Arankar sir. वागणं सुंदर, बोलणं सुंदर, स्पष्ट वक्तेपणा. थैंक यू सर. डॉक्टर बकुलेश मेहता, और चीयर लीडर, डाय हार्ट स्माइलिंग पर्सनॅलिटी. फ्रेंड्स, इथे आज जो प्रोग्राम ऑर्गनाईज केला आहे आपल्या संतोष खडतरे साहेबांनी, ज्यांना मी फॅरेक्स बेबी म्हणून नाव ठेवलं आहे पूर्वीपासूनच, आणि गुलगुल्या म्हणून संबोधतो, कारण तो एवढा गोड वागतो आणि एवढा गोड असतो, आणि त्याचं हे पण फार सुंदर आहे हो, फार सुंदर गातो हा माणूस एकदम. म्हणजे आय एम रिअली सरप्राईज की स्टेज कॉन्फिडन्स खूप सुंदर आहे गाण्यामध्ये, आणि गाताना तो नाचतोही, हे महत्त्वाचं आहे. त्यामुळे आय रिअली लव दिस काइंड ऑफ पर्सनॅलिटीज, यू नो. की काल तुमचा तो अमोल, मला आवडला त्याचं वागणं, बोलणं, म्हणजे मिमिक्री करू शकतो, गाऊ शकतो, प्रोग्राम कम्पेअर करू शकतो. हे अशा कला आपण जपून ठेवल्या पाहिजेत. फ्रेंड्स, मला मी एम्सकॉन अटेंड केली होती, तुमची अकलूजला होती. त्यावेळेलाही संतोष खडतरेने संपूर्ण लेडीज विंग उभी करून ठेवली होती फॉर द एम्सकॉनसाठी. म्हणजे क्रेडिटेबल, संपूर्ण सगळ्या लेडीजच होत्या टोटल. फक्त एकच संतोष जैन दिसत होता मला त्याच्यामध्ये. म्हणजे दॅट इज युअर कॅपॅसिटी, क्रेडिटेबिलिटी, की काम करण्याची पद्धत. आता इथे अकलूजला त्यांनी सेक्सकॉन पण ऑर्गनाईज केलेली आहे, फलटणला पण कॉन्फरन्स ऑर्गनाईज केलेली आहे. म्हणजे इज अ मास्टर इन ऑर्गनायझिंग कॉन्फरन्सेस अँड ऑल, डेडिकेटेड वर्कर. फ्रेंड्स, आता इलेक्शन आलेले आहेत, आपल्याला चान्स आहे प्रत्येक कॅन्डिडेटला भेटा. आपल्या सेंटरचा हेल्थ मॅनिफेस्टो त्याच्या हातात द्या. आपल्या ज्या व्यथा आहेत की अलेज अटॅक ऑन द डॉक्टर्स, बायोमेडिकल वेस्ट, महाराष्ट्र पोल्युशन कंट्रोल बोर्ड, नर्सिंग होम ॲक्ट, याविषयी थोडं सविस्तर त्यांच्याशी बोला, त्यांच्या कानावर पडून द्या थोडे चार शब्द. काही काही लोकांना तर 12वी झालेले नसतात, तरी पण त्यांच्या कानावर थोडे शब्द पडले तर त्यापुढे आपल्याला फायदा होईल की हे शब्द ऐकले होते म्हणून इलेक्शनच्या अगोदर, आणि ते त्याबद्दल ते संसदेत आपले प्रश्न मांडायचा प्रयत्न करतील. आणि मी तुमचा जास्त वेळ घेणार नाही. आता मेडिकल फॅटर्निटी इज गोईंग थ्रू द क्रायसिस, अँड इंडियन मेडिकल असोसिएशन इज अवर बिग एक्सटेंडेड फॅमिली. आता इथे एखाद पुढे जाणार, बाकीचे थोडे मागे राहणार, बाकीचे काही कट्टू हेवी दावे असतात, पण मग तेच मनात ठेवू नका, तेच मनात घेऊन चालू नका. एकमेकाशी ओपनली बोला, हॅव अ कन्व्हर्सेशन, रेग्युलर भेटत जा. त्याने काय होतं, वाद मिटतात, मनातला कटुता कमी होते, परत आपण एकत्र येतो, वाढतो. बिकॉज आपल्यावरती होणाऱ्या आघाताचा जर सामना करायचा असेल तर वी हॅव टू बी युनायटेड, अँड वी आर इन डेमोक्रेसी. डेमोक्रेसी इज अ गेम ऑफ नंबर. इफ यू आर युनायटेड यू आर गोइंग टू विन. इफ यू आर डिवायडेड नोबडी इज गोइंग टू टेक केअर ऑफ अस अँड ऑल. सो मी जास्त काही सांगणार नाही, बट प्लीज एन्जॉय द big extended family life. Thank you very much. Thanks a lot.
Thank you, sir, for wonderful and encouraging words. I now request Dr. Jayesh Lele, sir, to kindly address the gathering.
Our chief guest for the day, Dr. Shiv Kumar Utture, Vice President. President Dr. Thakre, IMA Maharashtra State. Dr. Ravi Wankhedkar. Dr. Anil, Dr. Ram Arankar sir, my very close friend, Dr. Bakulesh, Dr. Naurange, and all the team, and आजचे उत्सव मूर्ती Dr. Santosh Khadtare. And he very correctly, I remember somebody just now mentioned, the registration comes from him like anything. Because when we had arranged EVECON, I think about 10 years back, and we had requested, and he immediately sent a registration. So definitely today's program, I really congratulate the entire IMA AKLUJ team for organizing this great event. Very reciprocal, very informative, especially the yesterday's 4 or 5 lectures which I happened to listen. I got robots and lasers and other things, very informative. And today we are really working in Maharashtra is leading the front in all the respects of this technological. And I'm very much a technology man, and I was really very happy to see that all our doctors, even the inroads inside Maharashtra also, not only Mumbai. Even though I'm coming from Mumbai, these facilities are available, but outside also they are available in small places, and really it's really worth it. And I'm really happy that today's attendance also has been very good. Since I'm coming from headquarters, my request to Dr. Santosh would be, Santosh, please listen to me. So I would request the IMA AKLUJ team that IMA headquarters is building a new building now, which is many of you must have seen there whenever you have visited. So we are constructing a new building which will go for demolition in another 2-3 months' time, and mostly it will take about 3 years. At present, the building is about 35,000 square feet, which is going to be made about 80,000 square feet, and we need some funds we are gathering. From Maharashtra also we are given, individually also we are giving, IMA branches also are giving. So whatever contribution we are giving, getting it from the various funds, we should contribute. You can open the app, you can go to the website, directly you can pay. Even if a member pays 1,000 rupees, we'll be happy. So I would request Santosh to please give some money to the IMA headquarters, and please inform to the Maharashtra state so that we can collectively say how much Maharashtra contribution. Today IMA Maharashtra is nearly 50,000 members, and still we are adding more and more members, largest. But our contribution is at the moment, I think, number 4, I think, Dr. Utture. It is not number 1. So we should go slightly above. Of course, Gujarat is number 1. They have crossed way ahead of us, but definitely we can make some difference. And we are fighting almost a lot of issues, whether it's a Human Rights Commission, whether it's various cases, whether it's medical terminologies or writing. Yesterday somebody mentioned in one of the talks that not writing a capital letter, he got a punishment because there was a scene in the newspaper. So we are working on that, and our IMA's headquarters is versatile in nature. Lot of acts which are against the common faculty, which we are opposing it. Another 2 very important wings we are promoting is a medical student network and junior doctor network, because ultimately they will be the future of the medical faculty today, what we are having it. Many of us have done the medical practice maybe 20-30 years, but those students who are learning, they will be there, and we have offered them for 3 to 4 years deemed membership by just paying 1,000 to junior doctor networks, and for 500 rupees for 5 years medical student network. So they can participate in all the IMA activities, and we are promoting every branch in the vicinity, wherever there is a medical college, should actively get involved in joining those students, MSN and JDN, and help them to know what is IMA, because we have to nourish them, we have to see that those students do much more in future life, and then they will preserve the medical fraternity, because a lot of difficult laws are going to be pushed on us, and we have to fight it out. So IMA is doing that. Definitely, yesterday I mentioned another one very important IMA's National Health Scheme, which is for the members. I would request Dr. Santosh to send the forms to everybody. Those who can join, it will be very helpful. And Dr. Arankar sir, you know very well, is the Karta of the Social Security Scheme, even Dr. Nauranga sir, they are promoting it. So similarly, it is for the members. We are going to help out a needy person wherever there is an issue. Once again, I thank the entire IMA AKLUJ and IMA Maharashtra for organizing this very successful event. Congratulations and all the best.
Thank you, sir. Now I request the most dynamic personality of IMA, Dr. Ravi Wankhedkar, sir, to say a few words.
ज्यांचं आयुष्य जरी लहान होतं पण त्यांचं कर्तृत्व जगात महान होतं आणि त्या मातीत आपण जन्मलो याचा आपल्याला सार्थ अभिमान आहे. असा पहिला मानाचा मुजरा त्या शिवछत्रपतींना. कारण आपल्या प्रत्येकाच्या मनामनात रोमारोमात कणाकणात छत्रपती असले पाहिजे, ते भिनले पाहिजे, त्यांचे विचार भिनले पाहिजे. दुनिया की पहचान है औरत, दुनिया की पहचान है औरत, हर घर की शान है औरत. बेटी, बहन, पत्नी, माँ बनकर घर घर की जान है औरत. या सगळ्या माता माऊलींना माझा दुसरा मानाचा मुजरा. जिथे भक्ती, शक्ती, सेवा आणि समर्पणाची भावना आहे, अशी देशातील एक अत्यंत व्हायब्रंट IMA अकलूज ब्रांच, त्याला माझा तिसरा मानाचा मुजरा. आजच्या या उद्घाटन सोहळ्याचे प्रमुख अतिथी माझे सन्मित्र, राष्ट्रीय IMA चे उपाध्यक्ष, ज्यांना आम्ही थिंकिंग पर्सनॅलिटी म्हणतो, असे डॉक्टर शिवकुमार उत्तुरे सर. अत्यंत बहुआयामी व्यक्तिमत्व. तुम्हाला बऱ्याच लोकांना कल्पना नसेल, पण आपले राज्याचे अध्यक्ष डॉक्टर दिनेश ठाकरे यांचा कायद्याच्या बाबतीत, पुस्तक लिहिण्याच्या बाबतीत, एथिक्सच्या बाबतीत, लेखनाचा, कविता करण्याचा दांडगा अनुभव असलेले डॉक्टर दिनेश ठाकरे अत्यंत सिन्सिअरली, डेडिकेटेडली, कोणालाही न घाबरता आपल्या मताशी आणि आपल्या फ्रॅटर्निटीशी कायम एक प्रकारचं नातं जोडून ठेवलेले आपले माजी सेक्रेटरी जनरल, माजी राष्ट्रीय उपाध्यक्ष, महाराष्ट्र IMA चे माजी अध्यक्ष, आमचे मोठे बंधू डॉक्टर जयेश लेले सर. या ठिकाणी ज्यांना मी हरदिल अजीज असं एक व्यक्तिमत्व जे आहे आणि ज्याला मी नेहमी IMA चा हिरो नंबर 1 म्हणतो, ते IMA चे माजी राष्ट्रीय उपाध्यक्ष, IMA महाराष्ट्राचे माजी अध्यक्ष डॉक्टर अनिल पासनेकर सर. तसे ते नात्याने माझे सासरे लागतात. जरी जावायला काहीच देत नाही आणि प्रत्येक वेळेला काहीही मागितलं तर म्हणतं मुलगी दिली हेच तुला खूप झालं. असे चिरतरुण व्यक्तिमत्व आणि ज्यांना मी नेहमी जेंटल जायंट म्हणतो. आणि याही वयात IMA साठी कुठेही कधीही हजर राहणारे महाराष्ट्र राज्याचे माजी अध्यक्ष डॉक्टर बकुलेश मेहता सर. अत्यंत गुरुतुल्य व्यक्तिमत्व. अत्यंत शांतपणे परंतु मोलाचा सल्ला आणि मार्गदर्शनात, ज्यांच्या मार्गदर्शनाखाली आम्ही काम करतो, ते महाराष्ट्र राज्याचे माजी अध्यक्ष, आपल्या सगळ्यांचे लाडके डॉक्टर अरणकर सर. या ठिकाणी डॉक्टर नवरंगे सर इथे उपस्थित आहेत. ते आमचे गुरु देखील आहेत आणि आदर्श देखील आहेत. आदर्श या अर्थाने मी म्हणतो, त्यांनी मनात आणलं असतं ते कधीही महाराष्ट्र राज्याचे अध्यक्ष झाले असते. नॅशनल IMA कुठलंही पद त्यांच्यासाठी कधीही खुलं होतं, परंतु अत्यंत दुसऱ्यांना पुढे करायचं आणि कुठल्याही पदाची अभिलाषा न बाळगता जे भारतभर ज्यांच्या शब्दाला मेडिको लिगल क्षेत्रात अतिशय मोठं वजन आहे, ते आमचे गुरुवर्य डॉक्टर जयंत नवरंगे सर. अत्यंत जिंदादिल कपलच तसं आहे. आमचा लहान भाऊ आणि महाराष्ट्र राज्याचा कोषाध्यक्ष विक्रांत आणि नवनीत, राष्ट्रीय IMA CGPचे सहसचिव, खास औरंगाबादहून आलेले डॉक्टर यशवंत गाडे साहेब, IMA वुमन्स विंगच्या माजी राष्ट्रीय अध्यक्षा डॉक्टर मीना, महाराष्ट्राचे उपाध्यक्ष नितीन, सहसचिव जाधव मॅडम, या ठिकाणी आमचे सन्मित्र संजयजी देशपांडे आलेले आहेत, कन्व्हेनर अरवरी स्वप्नांजली आणि IMA अकलूजची संपूर्ण टीम, प्रकाश मराठे सर अतिशय सिन्सिअरली प्रामाणिकपणे महाराष्ट्र स्टेट सोशल सिक्युरिटी स्कीम सगळीकडे प्रत्येक ब्रँचमध्ये पसरवणारे असे आमचे खानदेशचेच आहेत ते मूळचे, त्याच्यामुळे त्यांच्याबद्दल आम्हाला विशेष लगाव आहे असे डॉक्टर प्रकाश मराठे सर. या ठिकाणी IMA अकलूजबद्दल त्या छोट्याशा सिमरजीतपासून तर इनामदार सरांपर्यंत एकोप्याने कसं काम करायचं याचा आदर्श घालून दाखवणारे IMA अकलूजचे अध्यक्ष संजय शीद, सचिव नितीन राणे, कोषाध्यक्ष निखिल, या सर्व वुमन्स विंगच्या राज्याच्या अध्यक्षा रेवती, गुजर मॅडम, सर्वच IMA अकलूजचे पदाधिकारी, नितीन एकतपुरे असतील. मला विशेष उल्लेख करावा लागतो की ऑर्थोपेडिक्स सारख्या वृक्ष ब्रँचमध्ये काम करून देखील इतका त्यांनी त्याच्यातला कलाकार जिवंत ठेवले आणि कुठल्याही प्रोफेशनलच्या गालात मारेल अशा पद्धतीने कालचं सादरीकरण करणारा अमोल शिंदे आणि तुमच्या आमच्या सगळ्यांचं आन बान शान असलेला संतोष खडतरे आणि त्याची जान असलेली सुप्रिया आणि उपस्थित सर्वच मान्यवर. खरं या ठिकाणी मी आजकाल IMAच्या खूपशा कार्यक्रमाला जात नाही, परंतु एक तर संतोषचं, आग्रहाचं आणि प्रेमाचं आणि हक्काचं निमंत्रण आणि दुसरी गोष्ट म्हणजे EVECON हा कार्यक्रम. मला माहीत नाही EVECONच्या कमिटीला देखील माहिती आहे की नाही, 2010 साली EVECON या नावाची कॉन्फरन्स सगळ्यात पहिले IMA धुळेनी घेतली होती आणि तेव्हापासून मला महाराष्ट्र राज्य IMAचा अभिमान आहे की त्यांनी ती दरवर्षी त्या पद्धतीने ती आता होते आहे. राष्ट्रीय अध्यक्ष 2018 साली असताना पासूनही आम्ही सतत वुमन डॉक्टर्स विंगला कसं प्रमोट करता येईल, कारण एक लक्षात घ्या, आज मेडिकल फ्रॅटर्निटीचं फेमिनायझेशन झालेलं आहे. म्हणजे 50% डॉक्टर्स या महिला आहेत आणि जर तुम्ही त्यांना IMAच्या डिसिजन मेकिंग पासून वेगळं ठेवलं तर IMA कधीच मजबूत आणि स्ट्रॉंग होऊ शकत नाही. कुठलीही IMA स्ट्रॉंग असण्याचे माझे 2च क्रायटेरिया आहेत आणि जे कधीच फेल गेले नाही. ज्या IMAत वुमन डॉक्टर विंग स्ट्रॉंग आहे आणि ज्या IMAची स्वतःची बिल्डिंग आहे ती IMA इनबिल्ट स्ट्रॉंग असते आणि स्ट्रॉंग होतच राहते. म्हणून सातत्याने सर्वांचा आमचा प्रयत्न असतो की महिला डॉक्टरांनी पुढं यावं. आणि बघा, अतिशय दुर्दैवाची गोष्ट आहे आणि आमच्यासारख्यांना लांछनास्पद गोष्ट आहे की गेले 96 वर्षात नॅशनल प्रेसिडेंट IMAचा फक्त एक महिला झाली. कालच सुप्रीम कोर्टाने बार असोसिएशनला निर्देश दिले की तुमच्या पदाधिकाऱ्यांमध्ये 30% महिलांसाठी रिझर्वेशन ठेवा. आणि आपण डॉक्टर स्वतःला अति उच्च शिक्षित सुसंस्कृत समजतो, परंतु आपल्या संघटनेची काय परिस्थिती आहे? हा महाराष्ट्र राज्य आपण म्हणतो संतांचा राज्य, पुरोगामी राज्य, या महाराष्ट्र राज्याची अध्यक्षा देखील अजून एकही महिला झालेली नाही. म्हणून म्हटलं ही लांछनास्पद गोष्ट आहे. आपण म्हणतो हरियाणा फार स्त्रियांच्या बाबतीत भेदभाव करतं, त्या राज्याची अध्यक्ष सचिव महिला होऊन चुकली. ओडिशा सारख्या राज्याची अध्यक्ष महिला झाली, आसाम सारख्या राज्याची अध्यक्ष महिला झाली. कधी महाराष्ट्र राज्याला महिला अध्यक्ष मिळणार आहे? केवळ कुठेतरी एखादं उपाध्यक्षपद द्यायचं, एखादं सहसचिवपद द्यायचं आणि त्यांची बोळवण करायची किंवा वुमन्स डॉक्टर विंगमध्ये टाकायचं, हे कदाचित हे चित्र आम्हाला सगळ्यांना मिळून बदलावं लागणार आहे. आणि ते बदलल्याशिवाय अजून IMA महाराष्ट्र ही स्ट्रॉंग होणार नाही. आणि म्हणून इव्हकॉन सारखे कार्यक्रम अशा पद्धतीने प्रत्येक ब्रँचमध्ये वुमन्स डॉक्टर विंग्सचे कार्यक्रम हे फक्त नाच गाणे आणि कल्चरल कार्यक्रमापुरते मर्यादित राहता कामा नये. जे संतोष करू शकतो त्याच्यापेक्षा जास्ती चांगल्या रीतीने सुप्रिया करू शकते, हेही मला माहिती आहे. परंतु ती माऊली संतोषला पुढे करते. ठीक आहे, तर अतिशय सुंदर नेटकं नियोजन, आयोजन आणि प्रयोजन सगळंच अतिशय देखणं होतं. यापूर्वी देखील IMA अकलूजच्या खूपशा कार्यक्रमाला मी हजर होतो. परत एकदा आपलं सगळ्यांचं आभार मानतो आणि पुढील वाटचाली शुभेच्छा देऊन इथेच थांबतो. जय हिंद, जय महाराष्ट्र.
Thank you, sir, for a wonderful speech. I now invite Dr. Shivkumar Utture, sir, chief guest of today's program, to kindly say a few words.
Namaskar. Good afternoon to everybody. Today, indeed, it's my privilege to be over here, and at the outset, before starting anything, I must apologize to the organizing team. I was supposed to come yesterday for a lecture, but due to some reason, right up till the last moment, it was not sure that I would be able to make it. But then, I think almost 3 times a day, Santosh was giving me a call. And once he does that, it becomes very difficult. So, luckily, I could make it, but I made it yesterday late in the night. So, that's why I apologize for that. And I thank you for having invited me here today. Maharashtra State President, Dr. Thackeray, sir, you have heard what type of a personality he is. जितका माणूस शांत असतो तितका माणूस आतून टफ असतो. And this is what is epitome of Dr. Thackeray. Especially as far as medico-legal things are concerned, legal things are concerned, not only that, but I think even branch constitutions are concerned, I think he agrasar aahe to ekdam pude, right? He has created everything, and I hope you all also go through whatever documents he has prepared for the state and for the national. My friend, colleague for years, Dr. Ravi, I think everybody, he has spoken about everybody, but let me tell you about this man. He was the first, I think, one of the only national presidents who took on the national government in the very first week or 10 days of becoming the president, national president. And we had that huge strike, which we always used to say was, as far as medical fraternity is concerned, we could never have a strike all over India, but that during his tenure, because he roamed about all over India, I think we were successful and we could stop a lot of things that were going to come, which would have been quite harmful for the medical fraternity. Then my friend again, and who was with me in the council also, Dr. Jayesh Lele, we have fought a lot of battles together. We have won some, we have lost some, but I think he is a man who will never stop fighting, and everybody has seen that. Dr. Anil, I think majority of you all know him. I have known him right from his college days. He is a great IMA activist, and a fighter, and knows when to say yes for anything, and rarely he ever says no for something. So he's that type of a personality. And then my gurus in IMA, Dr. Arankar sir, Dr. Bakulesh sir, Dr. Naurange sir, and these are the elders from whom we have learned what exactly is IMA and how to fight for IMA. So thank you very much all of you for having guided us all these years. We have the state leaders and office bearers, Dr. Gorpade, Dr. Jadhav, Dr. Gade, Dr. Marathe, who are over here, and the very fact that you have so many people from the state and the national who are sitting on the dais today. I think this is one of the biggest dais I've seen ever, around 20 people. And that credit goes to, I think, IMA AKLUJ and to Santosh for being able to collect so many leaders over here under one roof. President of AKLUJ branch, Dr. Sanjay Sheth, Secretary Nitin Rane, DWD Chiefs Dr. Revati Rane Madam, Dr. Swapnanjali, Dr. Arwari, and Dr. Gujar, who is the Chief of Women's Wing. And last but not the least, my close friend and colleague, Dr. Santosh. I think Santosh is a man who knows how to get yes from a person like me. So, always gentle, always very respectful to whomever he talks to. And you have heard just now that whenever he has had such big programs, he has got the support of the whole women's wing of AKLUJ. आम्हाला आमच्या एका पत्नीला मॅनेज करणं डिफिकल्ट पडतं. I don't know how he manages the whole show. And what do I say about AKLUJ branch? I think a branch which is about 200 plus, of which more than 100 of you with your families are over here. And the name of AKLUJ and of course Santosh has become almost synonymous at the Maharashtra state level. And it was possible for you to do all these things purely because of the unity that you have got in your branch. You work as a family, and that is something very few branches can boast about. And I hope you continue working as one unit even in the future so that you can achieve more and more. The only thing request to Dr. Santosh would be, and what I think just now Ravi has also said, that your ladies wing is active in AKLUJ. I think it's high time you start pushing them at the state level and then the national level also. You have got the potential. The thing is, you require that push to be given to all these. And from yesterday, I've been seeing the programs that you all are holding. I've also heard all the lectures which were there online when I was coming all the way. Even in the morning, I was hearing it online. I think beautiful lectures. And the best part is the theme that you have taken, robotics. I mean, this is the future of medicine. I've been giving talks on AI everywhere and what technological changes and how it is going to disrupt the whole way of how we are going to practice in the future. And even, and let me tell you, at the national level, we are contemplating having a separate wing as far as, AI is concerned, because that is what is going to be, that you have to follow in your day-to-day practice tomorrow. And whatever we have learned of whatever, may it be clinical, may it be investigative, whatever it is, the whole thing is going to change, I think, within the next less than a decade, when AI is going to play a big role as far as your clinical practice is concerned. And so congratulations for choosing such a topic over here today. So I bring greetings from IMA headquarters, so I'll just speak a few words of whatever IMA headquarters is doing, because everybody asks us, what is IMA doing for our members? Number one is the Charter of Demands. I hope everybody of you all have heard those 10 charters, main things that we have demanded from the politicians in this election time. My request is, please go to whoever are the who are standing for the elections over there in your area, for the MP elections. Please meet them and hand them over the Charter of Demands. Many a times I hear people saying that what is the use, they never listen to me. See, try and you will succeed. This is what we have learned right from our school days. We keep on trying. We have been successful in a lot of things. Like Clinical Establishment Act in Maharashtra, we have been successful in not getting the Clinical Establishment Acts, which is detrimental to our practice, for so many years in spite of the pressure from the central government on Maharashtra government. And that has been possible because we have kept on trying to avoid this clinical till they come out with an Maharashtra specific act which is conducive to how we are going to practice. And that document is already ready, which has been given to the government. Please go through the document. I think it is there on the Maharashtra state website. The second aspect is the issues of nursing homes, which I was supposed to talk yesterday. HBI has taken it up very, very seriously. May it be the MPCB issue, may it be the renewal of registration. Even at the Maharashtra state, we have taken this up. We know how difficult it is getting day by day for small hospitals that we doctors as IMA members, single or in jointly we own. Unfortunately, what I foresee is corporate hospitals are going to take over the whole thing in the future. So we have to avoid that. And to avoid that, we have to unify as one unit of small nursing homes. And the IMA headquarters and IMA state is also fighting on every issue. And today the greatest issue is the MPCB issue. All of you are aware. We are not getting our renewals because of that. We are working both at the national, and let me tell you, because of our persistent demands with the national government, the central government, which we were trying for the last almost 10 years to see to it that IMA becomes part and parcel of the committee formed by the central government as far as health issues are concerned. Health sector, we are the greatest healthcare sector that is there. And we have been successful because today, let me tell you, in MPCB also, there is one IMA representative who's there in the central board. There's one representative who's there in the state government MPCB board also. So they can, partake in whatever rules and regulations are coming, which is going to be conducive to us. And that is the strength of IMA, and slowly this strength is growing day by day. Even as far as human rights is concerned, just last 15 days back, I was in Delhi for the human rights. I was nominated by the central IMA. And let me tell you, there we took up two issues as far as our future youngsters are concerned. Many of us have our children who are in medicine. And these two issues that we took up was, one was the bond issue. And we have categorically told them that no to bond as far as IMA headquarters is concerned. We are not bonded labor, so our children and our youngsters will not be bonded labor as far as the government is concerned. So either they have to change their bond policy and make it so that their youngsters are encouraged to take up bond, or absolutely we do not want the bond. And let me tell you, even the Human Rights Commission was quite, whatever demands we were doing, they were convinced that they were right demands. And the second thing is the stipend issue that is there. Especially in the private medical colleges, we are finding that they are given, sometimes they are not given stipend, and even if they are given stipend, immediately that stipend is taken back, saying that hostel facilities and mess facilities, whatnot, they take it back again. So this is also what we are fighting, and IMA headquarters is fighting for single stipend in the whole state as per what stipend is given by the state government. That is what we are fighting for our youngsters. And let me tell you, both the MSN unit we have started, the JDN unit, that is the Junior Doctors Wing, these are going to be our future activists. These are going to be the strength of IMA in the future. So it is rightful that we fight for their rights so that they are attracted towards IMA. That's what's going to come up. Assault is another big problem. Just yesterday, in two places, one in Maharashtra and one, I think, somewhere in Kapathodia or something like that. Assaults go on taking place off and on. We are asking for a central act which is there, because as you know, in Maharashtra we have a state act, but all of us are aware that in the last so many years, 2010, if I'm not mistaken, that act has come into play. There has been only one conviction under that act, and there have been hundreds of assaults on our members. So we are trying to get it. There is some resistance from the National IMA saying that only doctor profession cannot be given this protection. Then the lawyers will ask, different other professionals will ask. But we are in a unique position where we are open to assaults day to day in our clinical practice. Because when a patient comes to you, remember the patient is suffering and he is coming for treatment. But what do the relatives feel? That once, in whatever condition the patient is brought to the hospital, his patient should completely get cured and walk back home, which is not possible. That is not in our hand. So this is the position that we are, and we are fighting. The National IMA is fighting to get a central act also as far as assault. It is going to take time, but it will happen someday or the other. Another thing, let me tell you that we are open to feedbacks from our general members. Many a times I have seen that some members have got some beautiful points to put forward, which can be taken up by the state IMA, which can be taken up by the National IMA. Please do not become a WhatsApp activist. It is very easy on WhatsApp to put what is IMA doing, why is IMA not doing this. Please come out with something that what should be done by all of us. Ultimately, what is IMA? IMA is every member who is sitting over here is IMA. So we are open both at national level and of course the state level also. So if you have anything to contribute towards, maybe, everyone is an expert in some branch or the other. Some people are experts in medical legal, some people are experts in nursing home issues, some people are experts in financial issues, whatever it is which helps our members, please put it down in writing and send it by email to the state IMA or the national IMA. And let me assure you that definitely it is taken cognizance of, and we will be working on that, because ultimately the strength of IMA is in the strength of the local branches. So Santosh, it is your job to make AKLUJ more and more strong, because when you make these local branches strong, we get the strength at the state level and the national level from your strength. So once again, thank you very much, all of you sitting over here who have invited me over here today and letting me talk about some issues as far as the National IMA is concerned. And congratulations to the whole AKLUJ branch. Congratulations to the whole Women's Wing branch also for doing such a fantastic program. Since I came, though it was late in the night, your hospitality was superb. The venue that you have chosen is excellent, and we have enjoyed our stay since yesterday over here. So thank you very much, the whole of AKLUJ branch. Thank you.
Hello. Thank you, Utture sir. Before presidential talk, we took two more felicitations. I request Dr. Utture sir to felicitate today's MOC, Dr. Padmaja madam. I request Dr. Pradna Gandhi madam.
Good vision.
Both MOCs are ophthalmologists. खूप वेळ झालेला आहे, 1:30 वाजलेले आहेत. मी गोरपडे सरांची माफी मागतो सर. मी डायरेक्ट प्रेसिडेंट आणि टॉकसाठी दिनेश ठाकरे सरांना विनंती करतो. डॉक्टर दिनेश ठाकरे सर प्लीज. गोरपडे सर सॉरी बरं का, गोरपडे सरांना बोलायचं.
Good afternoon.
I am very well aware that I am between you and the lunch. And also, the leaders traveling via Pune need to leave at the earliest to avoid the traffic jam. So, I will try to be short. Chief guest of today's program, National Vice President, Dr. Shivkumar Utture sir, past National President, Dr. Ravindra Wankhedkar sir, Dr. Meena Wankhedkar madam, Dr. Jayesh Lile sir, Dr. Amarkar sir, Dr. Bakulesh Mehta sir, Dr. Anil Pasnekar sir, Dr. Jayant Naurange sir, State VP Dr. Nitin Gorpade, Treasurer Dr. Vikrant Desai, State Joint Secretary Dr. Ashish Jadhav Madam, Agav Chale Chairman Dr. Yashwant Gade, Social Security Scheme Secretary of Dr. Prakash Marathi sir, AKLUJ President Dr. Sanjay Seth sir, Secretary Dr. Nitin Rani, Treasurer Dr. Nikhil, IMMS Women Chairman Dr. Revati Rani, Convener Dr. Supriya Arwari, Co-Chairman Dr. Swapnanjali Awad, whole team of IMMS, Women's Dr. Wing, Dr. Sanjay Deshpande sir, Dr. Navneet Desai madam, Dr. Anjali Gade madam, Dr. Arankar madam, and the man behind all this show since yesterday, Dr. Santosh Khartare. Along with him, whole of the EVECON organizing committee, along with Organizing Secretary Dr. Savita Gujar madam, all the leaders of IMA, all the office bureaus of IMA, faculties, speakers, delegates, and friends. Organization of a very successful and grand conference is not a surprise when it is organized by IMA AKLUJ. I think this is nearly 4th conference I am attending in various capacity, which were organized under the leadership of Dr. Santosh Khartare sir. I still remember when I used to take any batch entry level standards workshop for the whole day, and I was at that time very much surprised that branch like AKLUJ, which we feel at that time I used to feel that a small branch organized these any batch entry level standards. And when I went deep into the medical fraternity of IMA AKLUJ, then I came to know that it is the hub for medical facilities. Whatever comes in Solapur, usually Solapur is a district branch, but AKLUJ was, as far as medical fraternity facilities are concerned, they were at part with the Solapur and surrounding districts. Again, when I became president-elect, only 2-3 months after, Dr. Santosh Khartare sir called that we are willing to take EVECON 2024. So there was no question of saying no, and he was the first. I even didn't ask him who will be the WWE chairman, because when Santosh is there and we look after him, leader from this area, and the person responsible for the state. So he suggested the names, Dr. Revati Rani madam, and I was not knowing her, but more than my expectation, she conducted 2 webinars, Life Beyond Medicine, very excellent webinars, both of them, and just thoughts out of box, thinking out of box, speakers out of box. All the presentation in both the conferences was very good. And again, I saw the combination of OBGY, ISA, and IMA. All three various specialties sitting together and talking about non-medical things that was again a great surprise for me. And as rightly said by our treasurer, our leaders, we note as leaders when we travel that wherever women's wing is strong, that branch automatically becomes strong. And as suggested by our leaders, and that the women should now come forward at state level and national level. I wish IMA AKLUJ, WWI Maharashtra, rather I congratulate for organizing such an excellent conference, such an excellent hospitality, such an excellent venue. And yesterday, while opening the ceremony, opening the conference, I said that let's have fun in Fern. And Samarjit has proved it. He was the person who had fun in Fern. And that I just said that during the speech, but he really, I can say, enjoyed the things. And I will never forget him enjoying all the things. When you go home, you take some messages, you take some pictures, so visualizations, you can say. So I can't forget him, Samarjit, enjoying all the show. And of course, Dr. Amol Shinde, who really yesterday did a very great job. I was not knowing him in this capacity. I remembered Mira Bhayandar Hospicon, and I remember Dr. Navneet Desai in the same role there in Hospicon. So we have such personalities in our IMA. In capacity of IMA Maharashtra State President, I am supposed to talk about the issues of medical fraternity. I have talked about them yesterday, and most of you were there in that speech, heard me. So I will not repeat it. I will only say that whatever things, whatever problems, whatever issues are going, IMA leaders are working on it. If you have any issue, you should contact IMA Maharashtra through proper channel. And rest assured that each and every issue that comes into your mind is being addressed at state level and is being thought at state level. Times are difficult. We are being targeted on all the sides. Every strata of society is targeting us. Therefore, I will only repeat the one thing that I said yesterday. That is, it is time to save some time, to dedicate some time to save our practice. It is not that we are going to practice, we want to practice, very good, but it is now time to give some time for the practice, to save the practice so that we can earn, we can enjoy our work through this practice. So, I congratulate IMA AKLUJ WW team, and I am thankful to the WW team through Dr. Santosh Kadtare sir, who has nicely organized this conference, and the memories are there to cherish. I am thankful to all the leaders because this is the conference of state level, and all the state leaders, national leaders, they managed to come to this bit odd place for this conference. But I am very much sure that with all this organization, they enjoyed the things. And I am very much thankful to all of you, IMA AKLUJ and WW, for your contributions, inputs, and all the support you have extended to IMA Maharashtra State. I am thankful to you. Thank you.
Thank you, sir. After receiving lot of appreciation and praise from all the IMA dignitaries, I will request Dr. Nitin Rane, Secretary IMA AKLUJ, to conclude this inauguration ceremony with his votes of thanks.
First and foremost, sir, I would like to thank all the dignitaries present on the dais. from IMA AKLUJ and WW Wing especially for being present for this EVECON 2024 conference and blessing us with your presence and making this conference a huge success for us. It's been your blessings and your guidance that we are able to do such conferences. You have been helping us, guiding us for last 4 years. We have been in contact with you for conducting these conferences, and you have showed us the proper channels due to which we are excelling every year. And we hope to continue doing these conferences at such high levels. Thank you, sir. Thank you very much. Thank you, everyone.
I request all the dignitaries please be on the stage for the group photo. I request all the IMA AKLUJ office bearers and all scientific program MOCs to be present in the hall after lunch at 2:30 p.m. for the felicitation ceremony to be held by the hands of Honorable Dr. Rajiv Rane, sir. All the IMA office bearers, please be on the dais. Please, all the office bearers, please be on the dais for the group photo.
To all the one who are present over here, please, I would request everyone to check out because it's already past 12. The deadline was 12 o'clock. And if we are late more than this, they are going to charge the room again for the whole day. So I would request everyone to please check out.
Generation technology and apply it selectively where it's actually required. So this is how a patient consoles look in a typical Da Vinci system with all its arms. This is how we see it in the OT. You see India, the utilization of robotic assisted surgery is just about 1%. And that too, if you see urology takes the majority piece of cake, followed closely by gynecology. We are not far behind. Slowly it is increasing, and then gastroenterology. You see a markedly increased robotic installation in 2022 and beyond, where it's going on increasing. And the companies which are there, these are the 4 main systems for GI surgeries and gynec surgeries and urology: the Ugora, CMR, the Mantra, and the Intuitive, which is the age-old brand. Coming to the Indian statistics, slowly more and more surgeons are getting trained for this. More than 15,000 surgeries were performed robotically in 2021. So what is conventional lap? It's inserting trocars, performing the surgery, closing the stitches, and you're out. That's what makes it faster. Why is robotics different? Because everybody says, "Arey, docking mein bahut time lagta hai, it makes our surgery slow." But slowly your team learns to do it faster. And the best part is that the surgeon controls every movement, including the camera. So you don't have to shout at your assistant every time, "Hey, pass ja, dikha barabar," and don't need to get distracted from surgery. So this is how a typical gynec robotic setup looks. The big one with 4 arms is the patient console, which is on the patient, attached, docked. The center one is the instrument control with the screen and the cautery and the camera system. And the last one is the surgeon's console, where you can actually sit and operate. These are the variety of instruments. Now it is 8 mm ports which are used, and all forms, even clip applicators, are available. So this is how typically an OT works. You see, I'm the one who is operating the robot here. This is how docking is done. This is how the arms move. It rotates. You can rotate it according to surgery, where you're going to perform. If it's upper abdomen, there are options for it. If it's lower abdomen, there are options for it. And then you actually go ahead and push the entire system towards the patient. Oops, I think it's not forwarding. Yeah, is it? Forward नहीं होता क्या इसमें? ठीक है, it's not forwarding, so I'll move on. So that's how it's placed and got close to the patient, and then the camera port is inserted. Now you see that green target-like thing. This is targeting. You target the organ, and the arms will align itself according to the surgery. If it's liver, the arms will align accordingly. If it's uterus, pelvis, the arms will align accordingly. Then comes attaching the trocars to the robotic arms. Just like lap, you insert the trocar, and then there is a typical groove in which you fit the trocars, and that's how the arms are attached, and the instruments are fed into those trocars and attached to the robotic arms, and it moves. So this is what a surgeon actually sees inside. It's a totally 3D view. Now that's how it looks inside. You have to see through those binocular-like structures. And then this is how surgery looks in a robotic system. You have to sit. It's like how we are having a working lunch here. You can have lunch and also operate on a robot. So that's how simple it is. But you have to use all your 4 limbs, hands and both feet, as well as your mind. And as soon as you remove your head from the console, the arms will freeze. So there are no chances of injury. Whichever position you have left, the arms will lock itself. Going further, this is how the surgery is done. You can see the arms are moving, and similarly the movement of the hands and the feet, and the same movements being replicated exactly the same way inside. They are intuitive movements. You can rotate an instrument 360 degrees. As much as your wrist can rotate, that much the instrument will rotate. So this is how a case is being performed. I think I can't fast forward. So I'm just going to keep it on for some time and then move ahead because the video is not fast forwarding. So you can see how easily the instruments are moving. There is no restrictions. The tip rotates as much as your wrist can. And it's all precision micromillimeter cuts without any damage. And you see the camera can be moved according to the way you want it to move. You can zoom where you want to zoom. You can unzoom. You don't have to instruct anybody in the OT what they have to do. You are the boss. Even you can see even structures lower down in the pelvis, you can easily approach. Now I've purposefully kept a simpler case here for everybody to understand how it actually works. Now coming to this side, you can use the arms to retract as well and then go ahead and cut. One of it is a bipolar and the other is a monopolar scissors, but even harmonic, suction catheters, and even ligatures now available for attaching in the robotic arms. You can see how easily the vault is being opened without telling the camera person to move an inch. You're moving, you're operating, you're doing. Further going, this is the most easiest thing. People struggle for endo suturing in lap. They give up lap because they can't suture endoscopically. See how easy robotic makes it. You don't have to move a muscle. You just have to stand, and like you would suture in an open case, just operate on the console and the robot will the robotic arms will replicate those movements and the procedure will go on. So this requires less training and less practice, and you can learn it faster. So we all know the benefits: shorter hospital stay, fewer surgical complications, and shorter recovery times. But for the surgeon, it almost increases your surgical life by 10 years. Because in open and lap, you usually tend to damage your shoulders, your wrist, they're painful. In robotics, you sit and operate, and that's how your surgical lifespan increases much more. Going further, I won't say only robotics, because I'm primarily a lab surgeon, so I also want to show some good advances that have occurred in laparoscopic surgery. Now this video, unfortunately, if I'm unable to fast forward, I'll have to skip. This is wherein you can actually put, fast forward. Let's see if they can. This is just stenting the ureters with a infrared stent so that you can see them while operating and not damage them. So I think I can't fast forward it. So let's skip this video. Going further ahead, this is in the Olympus system. You can see everything yellow. That's because the fat enhancement mode is turned on. This will highlight the fat. Now you can see I'm doing retroperitoneal dissection here, and it's highlighting the fat and showing me the exact planes where to go. While dissecting, you'll just see in a moment, while dissecting over the ureter also, the fat around the ureter is appearing more yellow. So that will help us in preventing from, unnecessarily unduly stripping it. You can see that yellow layer is on the ureter. So I can just keep away from it so that I don't devascularize it completely while doing these surgeries. So these are the advances that have come in imaging systems using infrared. Going further ahead, this is a grade 4 endometriosis. I think I'll just let this video play for a bit because we all struggle in endometriosis because of anatomy. The anatomy is totally distorted and we have to find it. But with a simple ICG system, it becomes so easy. You just inject IV ICG, diluted, and then once you turn on the ICG, so you are confused where to cut. But as soon as you turn on the ICG, you can start seeing the structures. Now there the ureter has directly come in front, which couldn't be seen due to a frozen pelvis. So you can very clearly avoid it. You can see the lymph nodes on the vessels plus the ureter running laterally. Yeah, this is one slide which is comparing all the new systems that has ICG in it. Plus, this is used, I use it a lot in sentinel lymph node mapping in CA endometrium. Robotics also has it, is known as Firefly technology. You can see those green areas, that is the sentinel lymph nodes. So you just need to biopsy them, and then you can avoid a lymphadenectomy and unnecessary surgery in many of the cases. So what are the indications? Any case that is fit for a laparoscopic surgery is indicated for robotics. Gynecological malignancies, especially endometrial CAs, difficult endometriosis cases. And my aim today was to just introduce everybody to robotic surgery so that at least we know what it is and how it will benefit us, and highlight the newer innovations to make endoscopic surgery better for women, since this is EVECON. The biggest obstacles is easy access to laparoscopy. I won't call it an obstacle, it's a boon as well. Slightly longer operating time, high cost because instruments are still disposable, lasts only 10 cases. And unawareness, lack of many trained people to do it. And most importantly, ourselves, because we have to believe if change has to come. Today, this is a reality in many places. Like you said, you'll have love dolls. But for that, you'll have to wait till 2050. This is already there. So better we start using it now. Even in India, we see waiters, robotic waiters delivering food to all of us. So something is already knocking on our doorsteps. We just have to open it and let it in. So the biggest thing is we must believe first that we can change and we have to change. And it takes a lot of curiosity to learn, but it takes courage to unlearn. And learning is how you evolve, and unlearning is how you keep up as the world is evolving. So we have to accept change and we have to move ahead. Thank you very much.
Hello. Wonderful presentation, really wonderful. Rohan, as I fondly call him, as the Crown Prince of Dombivli, is doing great work. And Rohan, just one question, whether you've explored the possibility of single port surgeries in such cases.
Single port robotics is not yet come, it's just getting introduced. Only one place in India has it. I haven't tried it. Okay. We use minimal ports. 2 ports is sufficient. 3 ports, 1 for camera and 2 for instruments. Because the lesser ports you use, lesser is the cost of surgery for patient. Right. So as lesser ports we use is better.
Great. Any questions from the floor? So Rohan,
I think he has a question.
Yeah.
Yeah, everything is same as lab. Yes, CO2. Yes.
Okay, so I will wind up your talk.
Thank you.
With a poem dedicated to you and to your robo. Ki I told my robo to sweep my shack. He said, "You want me to sprain my shack?" He said, "You want me to sprain my back?" I told my robo to answer the phone. He said, "Sorry, I'm making calls of my own." I told my robo to boil an egg. He said, "First, let me see you beg." I told my robo, "There's a song you can play me." He said, "First, tell me how much you'll pay me." So now I'm confused because I never knew who is whose servant and who belongs to who. So I hope that phase doesn't come.
No. It will not come because the moment you leave the console, the robo freezes.
I know. And it is not the robo, but the hands behind the robo. We all agree. Thank you so much.
Thank you very much.
You were a wonderful speaker. Thank you.
Thank you very much.
Now I request Dr. Supriya Arwari ma'am to felicitate Dr. Rohan Krishna. All the chairpersons, please be on the stage. Lights लावा समोर.
Hello. Now the time for the next talk. I request Dr. Shweta Gugre Surana to be on the dais. Thank you, ma'am. I request Dr. Ujwala Shirsat ma'am to introduce our next speaker, Dr. Shweta. Presentation on, please. CV slide, please.
CVच्या slides.
Good afternoon to all. I take this privilege to introduce our today's speaker, Dr. Shweta Gugre Surana. She had done MBBS, MS Obs Gynae, DNB Obs. She is postdoctoral fellowship in fetal medicine, 2 years. Director at Pune Fetal Care Center, consultant fetal medicine at KM Hospital, Pune. And her interest in fetal imaging drew her to Mediscan system in Chennai, where she gained a fellowship in fetal medicine. She currently pursues her passion in fetal medicine and fetal therapy at KM Hospital. So over to you.
Thank you so much, respected chairmans. Okay, let me start this presentation with a question to all.
How many people can you see in this slide? Anyone? Absolutely, fantastic. So only in past decades, the fetus has been considered as a patient and has become a subject of extensive scientific study and attempts at treatment. So hi, I'm myself Dr. Shweta. In next 20 minutes, I'm going to take you through laser in fetal medicine. So we all are aware of mythological heroes, and this one is Ashtavakra. His father had wronged a sage, and so he was cursed that his child would be deformed in 8 places. To remedy the situation, the couple began narrating Vedas, and upon the birth, the child was physically deformed, but his mind was enlightened. So this story challenges us wisdom over physical deformities. It is important that the pregnant woman should understand what the condition of the baby is, under what circumstances the baby is in, and to stay positive to shape the destiny of the unborn child. So there are 3 types of lasers which are used in fetal medicine. First is the fetoscopic laser ablation. Here we have a fetoscope which is 2 mm, straight or curved, which is connected to the light source and the camera. And through, with the help of ultrasound, we put the fetoscope into the abdomen. This is done under local anesthesia. We prefer local anesthesia because we want the mother to participate in the surgery. Next type of laser. So this is fetoscopic laser ablation. Here, the fetoscopes allows us to intervene in conditions apart from twins, also in congenital diaphragmatic hernia, obstructive urinary abnormalities, and even more complex, the spinal column closure. Next, we can use is radiofrequency ablation. Here, we have a radiofrequency needle, and there are tines which open up in the fetus to ablate the fetus. This works at very high frequency, causing tissue coagulation and necrosis. So this can be used in twin pregnancy with severe anomaly, growth restriction, or twin arterial perfusion. Then we have this interstitial laser ablation, where we have an introduce a needle and the laser fiber with a special adapter, and with this we ablate the umbilical cord stump of the fetus. So there are several indications of laser in fetal surgeries, of which today we are going to concentrate on twins, especially the monochorionic twins. So the first condition is twin-to-twin transfusion syndrome. Now here in monochorionic pregnancies, there's a single placenta, so hence there are vascular anastomosis, due to which what happens is one fetus donates blood to the other fetus, and the one which donates the blood becomes oliguric, and hence there is oligohydramnios. And the other which receives more blood, the heart has to overwork and goes into failure, and the sac becomes polyuric. Once we diagnose twin-to-twin transfusion syndrome, the next step is to stage it. So the fetoscopic laser ablation is usually done in stage 2 TTTS. Now, without the treatment, the twins would die, and even if they survive, they will have neurological sequelae. So with treatment, there is 90% survival rate of one twin and 70% survival of both the twins. So this surgery aims at underlying pathology, that is the vascular anastomosis. Now I'll take you through the case. This was done in 2020. This was the first fetoscopic laser ablation which was done in Pune. So this patient was referred to us at 19 weeks as a monochorionic pregnancy. So one fetus had oligohydramnios and the other had polyhydramnios. The rest of the structures were normal. We called her up after 1 week because there was a oligopoly sequence. But the patient came at 21 weeks. After 2 weeks, the polyhydramnios had increased. In the oligohydramnios sac, the bladder was not seen because the bladder had collapsed due to oligouria, and the other side there was a prominent bladder. So here you can see in this picture, one side there is lot of liquor and other side there is very less liquor. Bladder is collapsed in the donor twin and prominent in the recipient twin. So this becomes twin-to-twin transfusion stage 2. We counsel the couple for fetoscopic laser ablation. Here we are putting the vascular sheath and the guide wire, and then we'll put the fetoscope inside, and we map the placental vessels for the anastomosis. So here you can see these are the vascular anastomosis on the placenta. This is intrauterine. 12 vascular anastomosis were identified, and then they were ablated. We also drained the liquor from the polyhydramnios sac. We followed this case. Next day, you can see this membrane is freely floating. On either side, there is liquor. The bladder, which was collapsed, now the donor twin has a bladder, and the cardiac status is turning towards normalcy. So this case we followed up 2 weekly. At 36 weeks, she underwent cesarean section. Both the twins, 2.2 and 2 kg, they are now 3 years doing well. So all cases are not a treat. Second case which was referred to us recently, as a second opinion, kidney is not seen and oliguria. So it was 17 weeks pregnancy, monochorionic pregnancy. So here we can see that in one sac there is very less liquor, and other sac there is more liquor. So we labeled it as TTTS, twin-to-twin transfusion stage 2. Now here you can see this is a membrane which is very snugly fitting one twin. This is the membrane which is engulfing the twin, and the other sac has a polyhydramnios. Now the challenge in this case was the placenta was anterior and the donor twin was completely stuck to one side. Hence they had referred to as kidneys not seen because of oligohydramnios, but the kidneys were well seen in this fetus. So at 19 weeks, she came back to us at 19 weeks. You can see here one sac there is polyhydramnios, the cardiac failure in the recipient twins. You can see the cardiomegaly, pericardial effusion. And now she went in TTTS stage 3. We counseled the couple for fetoscopic laser ablation. Here we've introduced the fetoscope inside. And 10 anastomosis were identified and ablated. So after you ablate the placenta, that is the single placenta, the anastomosis ablation looks like that. And single placenta becomes dichorionic placenta. That's the way to treat this pathology. So post laser, after a week, we could see liquor on both the sides, bladder appearing in both the twins. So we followed this pregnancy. However, there are complications of the surgery. So this twin had developed anemia in one side and polycythemia on the other twin. So this polycythemia and anemia are due to small vascular anastomosis, which we are not able to reach during fetoscopy. So on scanning, you can see that one side of placenta is hyperechoic and other is hypoechoic. The liver in the recipient twin, which is polycythemic, has a starry sky appearance. So this was the onset of another complication in already complicated twins. This was twin anemia polycythemia sequence. So we followed. Sometimes this resolves on its own. Sometimes it will need an intervention. So what happens in twin-to-twin transfusion? There are large anastomosis which we can see through fetoscopy and we ablate them. Small anastomosis which we might miss on fetoscopy still causes imbalance in both the twins and we are not able to ablate them, and then this complication arises. So at 25 weeks, you can see that the polycythemic twin, the MCA mom was 0.6 and the anemic twin had become severely anemic. There was cardiomegaly in both the twins. Now the two options were to repeat the fetoscopy or to do intrauterine transfusion for the twins. So fetoscopy repetition was not possible because the case was already very challenging. Placenta was anterior and anastomosis were not very well visible. So we opted for intrauterine transfusion to buy more time for the twins. Now in anemic twin, what we do is, this is the portal vein, we put the needle and we push O negative blood into the fetus. So we take the sample before doing the intervention. So this hemoglobin of this twin was 7.7, which was severely anemic. We transfused 54 ml of blood, and post-transfusion, the hemoglobin was around 15. In the polycythemic twin, we did partial exchange. In the partial exchange, what we do is, we remove the blood and we perfuse the twin with normal saline. So opening hemoglobin in this polycythemic twin was 16.7, and closing after the partial exchange, the hemoglobin came down to 14.4. So both the polycythemia and anemia were corrected. At 28 weeks, we did the neurosonogram for the babies. This lady unfortunately had PPROM, that is premature rupture of membrane, at 31 weeks. We did an emergency LSCS. Both the twins are doing well now, 1.2 and 1.3 kg. Neurodevelopment and echocardiography are normal for the twins. So second case where we are using laser in fetal medicine is selective growth restriction in monochorionic twins. Here what happens is, one placenta, the twin sharing of placenta is unequal, where one twin has more amount of placental sharing and the other twin has less. Hence, it becomes growth restricted. So there is classification for growth restriction, and we use laser for type 2 and type 3 selective SIUGR. So let me just speed up with the case. So this is a case of selective growth restriction, type 2, where one fetus had Blake's pouch cyst in the brain and the other fetus was normal. So we used RFA in this fetus. So this is the RFA needle. We are introducing into the fetus which is severely growth restricted. We position the needle near the umbilical cord stump and we ablate the stump. So this lady continued as a single pregnancy and delivered at 32 weeks. Baby weight was 3.2 kg, doing well. Next case is twin reverse arterial perfusion, where there is a pump twin and a cardiac twin. Now this a cardiac twin acts as a parasite, putting the pump twin at the risk of high cardiac output failure, and there is 50% demise if we don't intervene. Recently, we had this case of monochorionic triplet where there was one placenta and 3 babies. So all the 3 babies were sharing the placenta, but one baby was abnormal. You can see here there is a dilated ventricles and the spinal cord is open in the lumbar region. So this fetus had long segment myeloschisis. So we opted for interstitial laser ablation. So this is the laser fiber which is introduced into the introducer, and then we target the fetus. Here you can see this laser fiber, we are positioning it towards the stump of the abnormal fetus, umbilical cord stump, and we will ablate the stump. So now this pregnancy will continue as monochorionic twins. So this is the ongoing pregnancy. We are waiting, she's now 16 weeks. So what we have seen in fetal medicine is it has an opportunity to see and understand the life before birth. But it needs multidisciplinary discussion about the pros and the cons. Every form of fetal therapy is available in our country, but appropriate treatment is not always intervention. Fetal surgery has its limit, as our primary concern is do no harm. The surgery should clearly outweigh the benefits. In the end, I would end my presentation by thanking my mentors who are pioneers in fetal medicine in India. Thank you, IMA, for inviting me for this lecture. Thank you so much.
Actually, it's a wonderful talk, Dr. Shweta.
Yeah.
It's really eye-opener for all of us. I'm a pediatrician, so we are managing such cases, congenital anomalies, like diaphragmatic hernia, twin-to-twin transfusion syndrome.
Yes.
But it's really enlightening session for me too. Fetoscopic laser ablations for diaphragmatic hernia, like radiofrequency ablations.
Yeah.
And management of twin-to-twin transfusion by laser. And it's really great to hear that. More than 90% survival rate.
Correct.
You are doing good job. and intrauterine partial exchange, where we are doing it
Postnatally.
Yes. So I think it's a wonderful talk from your side.
Thank you so
You
much,
did good
ma'am.
job.
I have just one question. How much does a laser ablation cost? Sorry to ask, because patients will first
Correct,
come out
correct.
with that question.
Ma'am, the cost of laser ablation is 70,000. But since this is a research thing also, so we have fetal research unit where we have clubs who will fund the surgeries for the patients.
Great, great. Thank you, thank you.
Thank you, Shweta ma'am, for briefing us on what all therapies we can offer to a fetus.
Thank
I
you.
request Dr. Ujjwala Sirsat ma'am to felicitate Dr. Shweta Surana ma'am, and I request all the chairpersons to join. I request Dr. Rajiv Rane sir to felicitate one of our chairpersons.
I request Dr. Monica Misal and Dr. Priyanka Mahadik to come forward to chair manage the next sessions. The next session will be Women's Health WDW session, and the Master of Ceremonies will be Dr. Monica Misal, Dr. Priyanka Mahadik.
Hello and good afternoon, all the faculty members and delegates. I am Dr. Monica from IMA AKLUJ. As we know, after the delicious lunch and satiating food, that our brains has been captivating by that food. But now it's time for dedicate this session to the all women who have captured our heart in the form of kind and compassionate mothers, adorable daughters, and so is loving, caring wives. To begin the next lecture by our ravishing clinical secretary, Dr. Revati Rane ma'am. To chair this session, I would like to call upon the stage
Dr. Savita Guzar ma'am. Dr. Savita Guzar ma'am, dynamic and ever smiling gynecologist from AKLUJ and director of Guzar Hospital and Nursing Home. Dr. Vivek Guzar sir, the most experienced physician and director of Guzar Hospital and Nursing Home. Dr. Manisha Kadam madam, amiable and energetic gynecologist and director of Vatsalya Taste Tube Baby Center. And Dr. Mansi Inamdar ma'am, composed and charming radiologist from AKLUJ.
I would like to ask Dr. Savita Guzar ma'am to introduce. I would like to ask Dr. Mansi Namda ma'am to introduce our speaker, Revati Rane ma'am.
Hello. Yeah, today I have an opportunity to introduce my dear friend Dr. Revati Rane. Actually, she needs no introduction because she is the young dynamic gynecologist from the AKLUJ, and she is the backbone of this conference, EVECON 2024. She is the organizing chairperson of this conference. She is a high-risk obstetrician and gynecologist at Apex Hospital since 11 years. She's a IVF consultant at AKLUJ Fertility Center since 5 years. She's a newly appointed as Maharashtra IMA Women Doctors Wing Chairman. And she's All Maharashtra Obstetric and Gynecology Society Public Awareness Committee Chairperson also. Recently, she has also received Signature Award at Delhi in 2023 for her commendable work for womanhood in rural area. So she's a multi-talented lady. She has many more talents, but I don't have such time to introduce her in detail.
Thank you for that kind introduction, and it's my privilege to have my very good friend introduce me. Till the time he starts with that, first of all, I'm going to be very short and precise with my talk. This is the Women Doctor Wing session, and as we know, this is the Women Doctor Wing conference. So this session is the core and the most important session. Unfortunately, it is at the end, but I urge you all, because all the lectures are really wonderful. So I urge you all to please be present, mentally, physically here. So till the time we begin, I would like to start this session with small poem. This is dedicated to all the females who are here and who are listening online. So it is about umang. उमंग है कुछ करने की, उमंग है कुछ बनने की, जो सपने देखे हैं उन्हें पूरा करने की, समाज में नया बदलाव लाने की, अपना अस्तित्व बनाने की, उमंग है कुछ नया करने की, अपना इतिहास बनाने की, उमंग है कुछ करने की, उमंग है कुछ बनने की. So with this, we start this a very powerful session of Women Doctors Wing. And today I'm going to talk on a different topic, which is we all know we are facing it, but we are not addressing it. So this is about the biological clock which is ticking. So we know that as women, we try to, achieve everything and try to get it all. We juggle with time. We try to, have our family time, our exercise time, the everything, the profession, the finances. But with that, we cannot beat the time, because time is not our friend here. As it has been the term that I used was coined in, it is not something which is new. It was coined in 1978 by Richard Cohen, that the clock is ticking for the career women, which is outlined that the struggle for women who want it all and want to have it all. And, at some point of time, we cannot beat the biology, we cannot beat the physiology, and we cannot fight with the biological clock. And that is why they said that you cannot have it all. But no, the time has changed and the advances have come where, of course, women can have all what they want. So what is this biological clock? What are we talking about? So basically, women are born with certain finite number of eggs. So if you see here, Mala cursor mail, Siddhant cursor. So if you see here, at birth, suppose we have 100% eggs, which are 1.3 million. So at puberty, that goes down to 27%, and at the age of 30, as we see, it goes down to 12%, and at the age of 40, it is just 3%. So maximum females which are getting married now are thinking of getting married after like 27, 28, and then they plan, they want to enjoy their married life, and they are planning pregnancy at the age of 30, where you see the ovarian reserve is just 12% from 100%. So already we are getting married at the age where the fertility potential is falling. So fertility and fecundity, ability to get pregnant, it decreases. And the social fabric of India is also changing. See, Indian female are not same as European or American female. Our egg number is less, our egg quality is less. Unfortunately, that is the fact. So if we see, so here, at the age of 30 to 34, initially we thought that after 35, the quality of eggs goes down and the number goes down. But no, the fabric has changed. At the age of 30 only, there is sudden fall, if you can see, fall in the rate of fertility and increase in the rate of miscarriages. So yes, age is the most important prognostic factor when it comes to any infertility treatment. That is something we cannot change. We can change treatment protocols, we can change media, we can change injections, but we cannot change the age of the patient. So if you see here, at the age of 20 to 24, there is chance of 86% of pregnancy. Je purvi hot hota, there were early marriages, there were no problems or any issues, very less problems of getting pregnant. But now we are facing a lot of infertility patients because the age as marriage has gone up. So this is something that do we need to stop our girls dreaming to be someone who wants to be an athlete or go be a pilot or an engineer or do something with her life because she cannot have children, because she is not going to have that pleasure of being a mother. Because can we force every girl to get married at between the age of 20 to 24? The answer is no. So what we can do about it? So here another important factor about age is, it is not just because about the egg number or the egg quality, it is about the aneuploidy of the embryos. So there are a lot of chemical pregnancy losses, lot of embryos which are not implanted, and that is why the chances of natural pregnancies or the chances of infertility treatment goes down. If you see here, at the age of 43, there are chances of abnormal embryos is almost 80%. So how can we test it? Suppose like what I told you now, that in India there are a lot of females who are having premature ovarian menopause. There are many gynacs here, and we know that at the age of 28, 27, after 25 also many girls are coming with low AMH levels and poor ovarian reserve. So how can we test it? All of us, we have had our kids. All of us, we have, but this is not only for us. This is for our patients, this is for our daughters, this is for our daughter-in-laws who are going to come here, who are going to be very strong, career-minded females. So we check our hemoglobin, we do our routine tests, but do we check our fertility potential of our kids or of our daughters or daughter-in-law when they plan something for their future married life? So how can we test it? So basically, I don't want to go into detail, but the age is the most important prognostic factor, but we cannot rely on age. There can be a female of 35 years age who will have good eggs, but there can be a female of 28 years age who will not have good eggs. So we have to do AMH, that is anti-Mullerian hormone, and we have to do a simple sonography, transvaginal, to do her antral follicular count. So those are the two most important things which should be done before she plans her. For our kids, we plan so many things, for her admission, for going to 11th, 12th career. But this is also something, family life is also something which is very important. And as a gynecologist, now we are recommending, little bit early marriages, little planning pregnancies, first pregnancy early, or at least do something with your eggs so that you will have if you want it later. Yeah, so these are the tests that we should do. As ESHRE is the European society, which is the most standard society, which puts up guidelines for this, all the infertility workup. So they recommend these two tests. So as I told you, ART is something that we deal with, we try to fight with nature in that, and sometimes it is such a negative branch because here the age is not our friend. And when a patient comes to us and she is not ready for donor egg, if you see the green chart, after 30 to 32, the result starts falling. If she opts for donor oocyte and she has a poor reserve, then she has a similar, the blue chart says the similar success. But we cannot force anyone, or rather everyone has a right to go, have their own biological child. So for this, we have to consider doing egg freezing for such a specific class of females. So it is basically a patient is given injection, the oocytes are taken out transvaginally after anesthesia, and the oocytes are frozen. Freezing is something that we routinely do for semen, embryos. It is just taking those cells to minus 190 degrees, and in that temperature they remain alive and remain potent for infinite period of time. Yeah, so this is something which is not experimental. I am not coming up something which is, which requires a lot of further studies, but it has been, this is the American College of Obstetrics and Gynecology. It says that it is not an experimental thing. So we have to consider it seriously and think of doing it for our patients, our relatives. Yeah, so initially if you say that still there is no much awareness. People come to us now, we are 35, married since 8 years, आम्ही लांब राहत होतो किंवा करिअरचा प्रॉब्लेम होता आणि आता आम्हाला मूल हवंय आणि आता मग उसाईड कमी झालेत. Still young, educated people are coming like that. So only 2% of IVF cycles are done for oocyte freezing. If you see, the number of cycles using eggs, whatever eggs are frozen, they are not utilized later on that much. And but because now the technology of oocyte freezing has changed slowly to the fast freezing technique, now we are getting better oocyte outcomes and better results. Yeah, so there are many options, there are different scenarios. I'm talking about social freezing, but sometimes we have a young girl who has a ovarian tumor. Most of the times what happens is whenever patient comes to us or a surgeon or a pediatrician who is 12 or 13-year-old and she's diagnosed with a ovarian malignancy. At that point of time, we are so worried, the relatives are so afraid of her malignancy or losing her life that we do not think of her future marriage, her future potential to have kids. Most of the times, the oophorectomy is done of the same ovary and she is directly put up for chemotherapy and her ovaries are fired. Her life is gone. She cannot get married. And I know marriage is not everything, but from the place from we come from, for a family, it is very difficult to have a child who cannot have pregnancy, cannot get married, cannot have kids. So for this reason, there have been different, we can do directly, ovary can be taken out and can be preserved. Ovary can be transpositioned that we saw in the robotic surgery yesterday. So there are many ways. So here I would like to urge every surgeon, every pediatrician or every gynecologist sitting here, whenever we have a pubertal lady, a girl who has an ovarian mass, we have to consider her fertility options later on. Yeah, so these are some conditions. Another important conditions is endometriosis. We know many actresses, I don't want to take the name, that they have endometriosis and they have already frozen their eggs. Now they can wait till 38, 40 because they have their eggs frozen and they can have the pregnancy later on. But here we have to do counseling of the patient. It's very important because sometimes the frozen oocytes, when they are thawed, may or may not give good results. So accordingly, the counseling has to be done. Here, if that patient who is coming to you is already married, so it is better to take out the eggs, form the embryos, because embryos, they sustain the freezing better as compared to eggs. So it is always better to freeze the embryo than the egg. If she has a partner, they should go for embryo freezing and let them plan pregnancy whenever they want to. Yeah, so cancer we have already talked about. Some important points here that very low risk, if we go for targeted agents, we have to communicate with our oncophysician where we are sending our patient that if we are giving her targeted therapy, then her chances of her ovaries and endometrium getting fired is very less. Yeah, so here is one more point to be taken from this slide is that we do not want to risk her life. Her life is more important than her fertility, but that is why there are so many protocols. We need not have to wait for her menses also. We can directly start her from random protocols where within 10 to 12 days, we just need 14 days of her life to save her oocytes. That is what, as an infertility consultant, we are asking for. After that, we can give whatever chemotherapy we want, but those 14 days are going to give her better life later on. Yeah, so that is what I told you about slow versus fast freezing. Now the technique of fast freezing has come up, which causes less size formation, more oocyte retrieval, and the pregnancy rate is always equivalent to the fresh oocytes. So how many oocytes we want here? The only point important is if a patient is coming to us at the age of less than 35 years, usually if we see that, we get 16 oocytes, but if she comes to us at more than 40 years, so maximum number of oocytes that we get is 9. So chances of getting euploid embryos from that is very less. So take home message from this slide is, if you want to go for freezing, better to do it at younger age. Now at 38, अजून मला 1-2 वर्ष थांबायचं आणि मग मी करते, then already your chances have gone down. Yeah, so better freeze at early age and then your plan your life accordingly. So everything is age dependent, and again the chances of, if you see the number of euploid embryos at less than 35 years, if we see, the chances is 2.5% that we get those embryos, but at the age of 42, it's 0.1%. So again, it's not about the number of egg, it is about the quality and the embryos we are going to take. So overall, what we see, there are a lot of been studies that 51%, whatever patients who have undergone oocyte freezing, they anticipated their future. 95% would say, I would do it again if given chance to. 76% of them said, no, I would have done it at younger age. Yeah, and 10% they had regret for whatever reason, and 45% said that I would have done it if it was cheaper. So we need to work on protocols which will minimize the cost of this, and so that many patients, such kind of patients, can be benefited. आपल्याला असं वाटतं we are doing something abnormal, we are dealing or messing with the nature. So would it affect my oocyte? Would it affect the baby that we'll have? So no, the safety of egg freezing has been already established and studied, and it does not increase any chances of abnormality in your child. Yes, of course, with any procedure there are some small risk of oocyte stimulation and whatever, which is already there for any IVF procedure you go for. And yeah, as it is coming up, there are no long-term studies. I mean, we do not know that what happens to that embryo at when that baby is 35 years of age. But yeah, the studies are ongoing. So in short, age-related infertility is one of the biggest challenge that we are facing in modern medicine. Oocyte pool is fixed and declining with age. So ovarian reserve testing shows size of recruitable follicle, that is very important, and they can be cryopreserved with IVF success rate similar to fresh IVF oocyte. So as we said, the biological clock is ticking and we cannot fight with the time, but we can hold the time. We can set the timer and we can hold the time, and women can take charge of her life and can have it all. Thank you.
Thank you, Revati ma'am, for elaborating new point of view in oocyte freezing in view of preserving fertility for women in new era. I would like to ask Gujar ma'am to felicitate our speaker.
Thank you, Dr. Revati, for the wonderful lecture. No, it's very wonderful. Even as a radiologist, we loved it.
Now for the next lecture, he is the dynamic personality from Satara, not only in medical field but also in literature and expertise in co-curriculum activities, Dr. Shantanu Abhyankar sir, and his topic is Menopause Revisited. I would like to ask Dr. Vivek Gujar sir to introduce our speaker.
काढलं Actually, Dr. Shantanu Abhyankar needs no introduction. He has passed his UG and PG from BJMC Pune. He was the president of Satara and Obstetric and Gynecological Society in 2015 and 17. Chairperson of Sexual Medicine Committee, FOXY, in 2011 to 2013. He was the organizing chairperson of UA FOXY 2010 and AMOX 2019. A well-known writer, orator, blogger, innovator, and TED speaker. He has 8 million views on his YouTube. He delivered several orations. Over to you, sir.
Thank you, sir, for that introduction, and thank you, Revati, for having invited me here. And thank you also for putting up all those videos on social media which educate the patients from time to time. I believe that is a very, very important task that you've taken up for AMOX. Now, I am here to talk about menopause revisited, so I'll only be talking about the changes that have come up. There is no presentation, it's me who is going to present. So you have to look at me. हाँ लाइट चालू करा. So the update is that there is a pendulum swing. We have the Women's Health Initiative data now, and maybe in our college days we learned that all women should receive hormone replacement therapy, which is no longer the case. So we actually look for an indication, rule out all, see to it that there are no contraindications, and only then put the woman on this. I'll try to be as brief as possible and give you just the bullet points. So we assess the benefits and risks. There are also changes in the age and the time since menopause that we are giving this. It has to be started, if at all it has to be given at an age earlier than 60 years of age, and is best started within 10 years from the last menstrual period. It is no longer called hormone replacement therapy. It is called menopausal hormonal therapy, because we are not replacing anything. We are only assisting the body in whatever problems it has landed up because of some hormonal changes. It is most effective in vasomotor symptoms, which are the most commonest problems with menopause, and women suffer from these vasomotor symptoms, which are very, very real. It is also effective in genitourinary syndrome, wherein it leads to dryness of vagina, some urinary incontinence, and itching, and such other things, and in osteoporosis. So these are the things in which it is really, really very, very helpful. There are other benefits, though we don't actually treat these conditions with hormone replacement therapy. Either keep the lights on or switch them off altogether. So there are other benefits, though we don't use these as indications, but these are the sort of beneficial side effects of this particular management strategy. So the sleep will improve, the joint and muscle pain will go away, mood swings will be less. There is an improvement in sex life, especially due to certain agents, and decreased chances of colonic cancer, decreased diabetes and metabolic syndrome, and possible benefits on coronary vascular disease and even cognition. Coming from the indications, we move to the absolute contraindications, which we must know. History of estrogen-sensitive breast cancer is an absolute contraindication. History of endometrial malignancy is an absolute contraindication. Active liver disease, thromboembolism, and undiagnosed vaginal bleeding. The textbooks also list pregnancy as one of the contraindications, but then I really don't know why it is there. It's quite obvious, since we define menopause as 1 year of cessation of menses. Pregnancy, I believe, is practically ruled out. Anyway, so I told you that it is now menopausal hormonal therapy. There was a condition defined as premature ovarian failure. Now we have another. And then there is premature menopause, which is now called premature ovarian insufficiency, meaning thereby that in premature ovarian failure, there is a chance that the woman will regain her menses and maybe even have babies later on, whereas in premature menopause, this does not happen. It is defined as menopause earlier than the age of 40. We are using as low dose as possible, and I'll come to the doses in a little while. And we are using less androgenic progesterone. So no medroxyprogesterone acetate or norethistérone is used in hormone replacement therapy. If at all, you have to add the progesterone. And surprisingly, it is found that it is the progesterone that is related to the increased chances of breast cancer and not the estrogen component of it. So the estrogen remains, and the progesterone is the one that we have switched from medroxyprogesterone and other androgenic progestrogens. There is a drug called ospemifene, and it is especially useful for vaginal atrophy. And women who have sexual problems would be helped with this. And then there is the TSEC, tissue selective estrogen complex. We'll come to it in a little while. So the conventional hormone therapy that was offered to symptomatic menopausal women, not as a prophylactic to anything, symptomatic menopausal women, is only estrogen if the woman does not have a uterus, and estrogen plus progesterone if the woman has a uterus. You can give them in a sequential fashion if she is perimenopausal, or continuous estrogen and progesterone if she is well into her menopause. Then there are selective tissue enzyme activator regulators such as tibolone, and of course I mentioned the TSEC. It is recently now is available in India. It's a combination of bezadoxifene and equine estrogen. So this is the most effective. And how long do we continue? As long as the woman requires. It is not that you stop at 60 years of age or stop at the natural age of menopause, as long as she requires. Only in girls with premature ovarian failure who have lost their ovarian reserve very early, we continue it till the natural age of menopause and then stop it. We may add it back again, start it back again if they need it because of menopausal syndrome. This leads to greater acceptance by the women. Now, this particular change from the Women's Health Initiative to the newer guidelines, it came because of two trials. One is called the HOPE trial and other is called the Replenish trial. And one of the important things that these trials underlined was that regardless of the BMI, the low doses are effective, which is such good news. So irrespective of age or BMI, we can start with the low dose. How low? Usually it is the conjugated equine estrogen that is started, not the 0.625 that is the standard dose available, but 0.3 milligrams. And the estradiol, 1 milligram and not the 2 milligram. The starting doses are at least this.
One needs to get screened. None of them, they get screened because they feel that if we get screened, in case we come positive for that, that would be a very difficult, time consuming, and they'll require money, a lot kind of money. So they won't go for a screening. कारण स्क्रीनिंग केलं की आपल्याला होणार कॅन्सर ही एक भावना आहे आणि त्यामुळे आपल्याला त्याच्या पलीकडे जाऊन आपल्याला समजून सांगायचं आहे. प्रायर हिस्ट्री ऑफ लोब्युलर कार्सिनोमा इन सिटू, व्हेरी इम्पॉर्टंट. आजकाल सर्वांना सेल्फ ट्रीटमेंट हवी आहे. हेल्दीफाय अँड वॉट नॉट ॲप्स आर अवेलेबल ओव्हर देअर. सी, फर्स्ट थिंग, प्लीज डोंट किल द जॉय वॉट एव्हर लेफ्ट you have in your life. So I always feel this, that by replacing your morning coffee with green tea, ऐकायला खूप सुंदर वाटतं green tea, but then you can lose up to 87% of whatever little joy you still have left in your life. So please don't go for anything hi-fi. Please be simple and as easy as possible. काय अवॉइड करायचं आहे? आय थिंक सर्वांना माहिती आहे. मेडिकोज, नॉन मेडिकोज, नॉन IMA, एव्हरीवन नोज. अल्कोहोल, टोबॅको, प्रोसेस्ड फूड, ओबेसिटी. Obesity again, easier done than said. Easier said than done, I would say. So there are ways to tackle once you accept few things. Accept that you are obese and then you will be able to solve the problem. आजकाल acceptance-लाच problem येतोय. People say no body shaming, that I'm against that. Body shaming is a good thing, but provided there are some results. Otherwise, you just can't say that, okay, I'm quite good, I'm looking good, and I shouldn't be body shamed only because I'm fat or I'm obese. It's okay. Just accept it and know that this is a wrong thing. You need to change it. Breastfeed kara, the best thing, easiest thing. I think all mothers over here, they must have understood simplest way to feed your child is breastfeeding. Exercise, an active lifestyle, balanced fiber-rich diet, vitamin D adequacy. Tropical country मध्ये मला हे कळत नाही की 80%, 70% are vitamin D deficient. That is absolutely like unbelievable. Countries, other countries which don't get enough sunlight, they are surprised to know that Indians are deficient in vitamin D. That is because we don't expose our skin properly to the appropriate kind of light. Yeah, I'm almost ending it. So sunlight is very important again. पण कपडे घालून नाही. I think sun bath should be encouraged. So this is something, the barrier has to be broken. आणि सनलाईटमध्ये थोडा वेळ घालवा. जसं जुने लोक जे अंगणात बसून जेवण वगैरे करायचे, न्याहारी वगैरे करायचे, नाश्ता करायचे, आय थिंक दॅट हॅज टू कम इन टू द पिक्चर. सर्वायकल कॅन्सर, डोंट पे अटेन्शन टू दिस, नॉट व्हेरी इम्पॉर्टंट. अगेन हाय रिस्क म्हटलं तर आपल्याला नेहमी वाटतं चला आपण हाय रिस्कमध्ये नाही आहेत, बट लेट मी गो थ्रू इट. मल्टिपल सेक्शुअल पार्टनर्स, ओके. आता a catch there is multiple sexual partners, पण त्यामध्ये if a sexual partner, even if you have a single sexual partner who has another sexual partner who has CS cervix, then you are at a greater risk. So even if there's a single partner but he has a infected partner, that is also high risk. Early age of sexual intercourse, now this thing I think increasing the marriage age doesn't change that. So it's something that concerns me a lot but can't be avoided. Only thing is that the awareness has to be increased. Barrier contraceptives and all, they should be freely available for this youth. History of HPV infection or condyloma or both. History of herpes simplex virus infections, vulval cancer, immunodeficiency, you just name it and all, everything is there as a high risk. Now I think just eating food also will be in high risk after few years. Because everything has so many carcinogens in it that this is like with westernization you will get the western country illnesses in India as well. So in western countries every family has a person who has died of cancer. So now I think in the coming years we will also have one person who has died with cancer. So it is not a long time dream, it is something that is there waiting at our door and knocking. So I think this is the time when we should start screening. लो सोशिओ इकॉनॉमिक स्टेटस, अगेन काही फरक पडत नाही, हाय सोशिओ इकॉनॉमिकमध्ये पण होतं. वी हॅव सीन व्हेरी हाय फाय विमेन हू डोंट नो हाऊ टू हॅव अ गुड प्रायव्हेट पार्ट हायजीन. सो दॅट हॅज टू बी इनकल्केटेड इन फॅमिलीज these days. Smokers and abusers of other substances, including alcohol. Now smoking as well as passive smoking. Passive is more dangerous since a smoker at least has a filter. But a passive smoker doesn't even have a filter. So that is more dangerous for that person. स्क्रीनिंग टेस्ट कोणकोणत्या अवेलेबल आहे, एव्हरीवन नोज दिस. पॅप्समियर आहे, लिक्विड बेस्ड सायटोलॉजी आहे, कॉल्पोस्कोपी, को टेस्टिंग विच इज लाईक इन वोग दीज डेज. आता आजकाल सगळे पेशंटही येऊन म्हणतात को टेस्टिंग करा म्हणून. अनदर थिंग इज दॅट यु नो, जसं मी सांगितलं की स्क्रीनिंग टेस्ट सिम्पल हवी आहे. म्हणजे एक नॉन मेडिको, एक आया असेल, सिस्टर असेल, मावशी असेल, टीचर असेल, तिलाही करता आली पाहिजे. सो आय थिंक इट्स फॅड वगैरे सगळे बाकीचे जाऊ द्या, पण आज आपल्याला ज्याची गरज आहे ते करायचं. आणि दॅट इज सिम्पल व्हिज्युअल इन्स्पेक्शन. यू कॅन यूज ॲसिटिक ॲसिड, दॅट्स द सिम्पलेस्ट वे. सगळ्यात सोपं, स्वस्त अँड कॅन बी डन बाय एनीवन. रिझन्स काय काय आहेत, वी हॅव ऑलरेडी डिस्कस दॅट. लॅक ऑफ नॉलेज, अ फॅटॅलिस्टिक ॲटिट्यूड टुवर्ड्स कॅन्सर. कॅन्सर व्हायला नको म्हणून चेकच नाही करायचा, शुगर व्हायला नको म्हणून चेक नाही करायची. नाव आय डोंट थिंक एनीवन कॅन अंडरस्टँड दिस, पण हे होतंय आणि वी आर ऑल्सो द कल्प्रिट समवेअर. एकदा एकाला CA समजला की आपण त्याला इतकं घाबरवून टाकतो ना की स्क्रीनिंगमध्येच की असं होऊ शकतं, ते होऊ शकतं, जस्ट थिंकिंग की अरे आपण नॉलेज दिलं पाहिजे. अरे पण तुम्ही नॉलेज जे देताय ते जर अप्रोप्रिएटली नाही देताय, इफ यू आर गोइंग टू टेल दॅट पर्सन की स्क्रीन करताना यू मे गेट कॅन्सर, वाय इज दॅट पर्सन गोइंग टू कीप द युटरस ओव्हर देअर? सो इफेक्टिव्ह awareness is, again, you can't stress more on that. Lack of knowledge by the medical and paramedical, including us. And हे जे सगळ्यात इम्पॉर्टंट आहे, डिसऑर्गनाइज्ड स्क्रीनिंग प्रोग्राम. स्क्रीनिंग प्रोग्राम कॅम्प एका ठिकाणी होते, तिथे स्क्रीन होत आहे, ती व्यक्ती परत दुसऱ्या कॅम्पमध्ये जाते, तिथे स्क्रीन पॉझिटिव्ह होते, तिसरीकडे जाते, स्क्रीन पॉझिटिव्ह होते. दे आर जस्ट फाइंडिंग, सर्चिंग अ कॅम्प वेअर दे विल स्क्रीन नेगेटिव्ह फॉर दॅट. सो they are not followed properly. Disorganized असल्यामुळे हे सगळे प्रॉब्लेम आहेत. प्लीज हॅव समथिंग ऑर्गनाइज्ड अँड विच आय थिंक ओनली गव्हर्नमेंट कॅन डू. प्रायव्हेटमध्ये इट्स व्हेरी डिफिकल्ट टू कीप अ फॉलोअप. अ सिम्पल LBC, अ लिक्विड बेस्ड सायटोलॉजी, विल टेक समवेअर अराउंड 1,000-1,200. अगेन 400-500 डॉक्टर्सची फी. 1,500 द्यायचे हे समजून घ्यायला की मला काहीच नाही आहे, त्यापेक्षा आम्ही काही न केलेलं बरं, सिम्पटम येतील तेव्हा बघू, हा ॲटिट्यूड झालेला आहे. अँड लॅक ऑफ equipment, healthcare facilities. Now, if you don't have a colposcope, definitely you can't do anything. I have seen hospitals who don't have acetic acid. And then I told, like, I won't name someone, but then I just gave an idea. See, you must be having vinegar in your kitchen, right? So that is acetic acid. And then it was like, oh, this is something that we have everywhere. But still, why is it not in the hospital yet? So every gynec hospital should have acetic acid, a speculum, sim speculum, and every woman who comes there should get, according to me, this is what I offer. Every 35 plus ला VIA करा acetic acid ने free of cost करा ती आयुष्यभर तुमचं नाव घेईल. ठीक आहे? So that is the best thing a doctor can offer. Genital hygiene, screen and diagnose early, and HPV vaccine. Now vaccine is something that we have got. Just imagine कोणत्याच कॅन्सरवर वॅक्सिन नाहीये, सर्विक्सवर मिळत आहे, जे की सगळ्यात मोठं कॉज ऑफ डेथ आहे. We had seen that pie chart. 30 to 35% कॅन्सर जो आहे त्याच्यासाठी जर वॅक्सिन मिळते, एक लस मिळते, सो हू वोंट टेक दॅट? अ फूल ओनली वोंट टेक दॅट. आणि इट्स व्हेरी डिसहार्टनिंग टू से दॅट वी ऑल आर फूल्स ओव्हर हियर. ठीक आहे, किती जणांनी वॅक्सिन घेतलेलं आहे? कॅन यू प्लीज रेज युअर हँड?
No one.
See, we just have 2 people, including me, 3 people. I've taken 4. So I've taken that vaccine 10 years back. कोणती वॅक्सिन बाजारात आली तर पहिले हेच होणार की ती खराब आहे, त्याचे काहीतरी प्रॉब्लेम्स असतील, ओव्हेरियन इन्सफिशियन्सी, प्रीमॅच्युअर ओव्हेरियन फेलियर. Mind me, let me tell you, I have a very good obstetric history. I have 2 lovely kids. I had taken that vaccine. I don't have PCOS, anything, no ovarian failure, nothing. So, you know, it's better to die with PCOD or with ovarian failure rather than dying with cancer. You know, it's that easy to understand. So vaccine,
sorry to interrupt, but we are running very
short. This is the last slide.
Please.
This is the last slide. सर्व वॅक्सिन उपलब्ध आहेत. 3,500 मध्ये क्वाड्रावॅलंट मिळते आणि नॅनोवॅलंट अराउंड 10,000. आय डोंट थिंक दॅट इज व्हेरी डिफिकल्ट टू लाईक, इट्स नॉट काइंड ऑफ लाईक नॉन अफोर्डिंग. सो एव्हरी वन हॅज टू टेक दॅट. आजकाल गव्हर्नमेंट प्लॅन्समध्ये पण अवेलेबल आहे. ओके, the recommended age, everything is available, everyone can take it. 26 च्या पुढे किती बेनिफिट होतो सांगता येत नाही, पण बेनिफिट थोडा जरी झाला, आय थिंक 10% जरी झाला, so is it less? No, it is not less. And love yourself. Thank you.
Thank you so much, ma'am, for this wonderful lecture. I would like to ask Dr. Mansi Inamdar ma'am to felicitate our speaker.
The next lecture will be on mental health in females. It will be delivered by the Iron Lady in a Mediqueen beauty pageant, a vivacious gynecologist from Mumbai. And a little gossip we had yesterday night, that she told me that in the last lecture there will be only me, Revati ma'am, and Emosis will be there only. But see, ma'am, still there are few people for your lecture. So please.
And she is a very good shire, so I'm hoping to, you know, get one good shayari to begin with, yeah. And I assure that everyone will be happy that they waited for this lecture. She is such a good orator.
Chairpersons, they'll also be present, no, obviously.
I would like to ask Manisha Shinde ma'am to introduce our speaker.
It's my privilege to introduce a charming lady, Dr. Supriya Alvari ma'am, consultant obstetric and gynecologist and infertility specialist. She has done her UG and PG from KEM Hospital, Vadia Maternity Hospital, St. GS Medical College. Practicing at Supreme Hospital, Bhiwandi for 20 years.
It's okay, fine. I will introduce her brain with beauty. One line, finish.
Oh, so sweet. Thank you. Respected chairpersons and organizers of EVECON, I am the closing batsman. You know, normally the last speaker says, I am standing between you and lunch. Now the lunch is also gone. So
you are Dhoni, ma'am. You are Dhoni.
Your departure home.
You are Dhoni. You are the finisher.
So I'll keep it, you know, short and sweet. Thank you, Revati, for having me here. Thank you, Swapnanjali, all you beautiful women and men who are waiting back. अधूरी कहानी पर खामोश होठों का पहरा है, चोट रूह की है इसलिए दर्द गहरा है। अकेले मत रो, दिल का बोझ उतार दो, आंसुओं को समंदर को किसी कंधे का आधार दो। मत रोको अंदर के सूनेपन को, कभी समझो कभी समझाओ अपने अंतर मन को। Thank you. And if you are wondering why I am talking about mental health, so let me tell you, I am a psychiatric, not patient, but psychiatric doctor's mother. My daughter is a psychiatrist. Well, that doesn't qualify me to give a mental health lecture, but yes, I am going to try my best because this topic is very close to my heart. We all know mens sana in corpore sano, always a sound body only with a sound mind. So if your mind is not sound, your body is not going to be sound. And therefore, I am running a project Mananti with AMOGS, that is the Association of Maharashtra OBGYN Society. And we plan to, already we are underway, and we plan to take up more mental health issues, mental health sessions for doctors, for the public at large. So now let us discuss why we are even talking about mental health, and that too at the end of the talk. कि आपने खा पी लिया, पेट भर लिया, अब मन भर के आप वापस जा सकते हैं, right? WHO constitutes the definition of health as a state of complete physical, mental, social well-being and not merely absence of disease or infirmity. इसका एको कम कर सकते हैं? नहीं तो मैं गाने लग जाऊंगी एको। In underserved population, activities have tended to focus on issues related to reproduction such as family planning, childbearing, everything in women's health, but women's mental health has relatively been neglected. 45% of women with mental disorder and have activity limitation. Now this is a huge number. We are talking about 50% of the population which can contribute positively to our country, to the growth of the nation. And of these 45%, so nearly half women are going to be in some point of time or the other incapacitated due to their mental health disorder, especially between 18 to 44. That is the most reproductive time, not only reproductive function wise, but otherwise also a productive time of your life. Sorry. Okay, why women are more prone to psychiatric illnesses? Mental health of women must be considered in the context of their lives, because they are multitasking, they are, waging wars on various fronts. Okay? For example, a man comes home and he'll say, I'll help you with the chores. Why does he need to say help you? Is it not his chore too? He should be saying, I'll do my share of the chores. He will say, I'll help you with the chores. जो अच्छा है, करता भी है तो भी at the back of the mind उसके दिल में रहता है, ये इसका काम है, मैं मदद कर रहा हूँ. नितिन वहां से देख रहा है सब गुस्से में एकदम. Okay, overall equal number of women and men get diagnosed of mental disorders. However, depression, panic disorders, general anxiety disorder, GAD, OCDs, PTSDs, are eating disorders, somatization disorders are significantly greater in women. The gender disparities, basically genetically women are more predisposed. Hormones are playing havoc in their life right from a young age. You know, the changes, number of changes that, hormonal changes that we undertake. Trust me, if the men had to do even 1/10 of that, they will all be admitted to the psychiatric hospital. Neurodevelopmental differences, neuropsychological or physiological changes, difference in the stress receptivity. See, nature has made women more emotional, more receptive. If you all have read the book, Men Are From Mars and Women Are From Venus, the crux of the matter is why women are like this and why men are like that. Because women have been prepared for motherhood. Imagine, एक आई जी नुसती अशी है तो छोटू धावतोय ना, with all those male hormones raging, अशी बाई असती तर how well can she look after the child? She will, म्हणजे नुसतं त्या बाळाला पकडताना सुद्धा, you see the touch of a mother, see the touch of a father. I remember when my daughter was born, my mother used to say, अगं तुझ्या नवऱ्याला सांग तो एक दिवशी हाड मोडेल तिचं, आणि त्यांनी खरंच मोडलं एकदा. He just picked the khel, mastiche khel karta karta, he had dislocated. See, that is the difference, that a woman has been made gentle, soft, so that she can look after her children well. She doesn't harm them while she is bringing them up, you know. And that is why they are more receptive to these emotional changes, to emotional disorders. What are the psychiatric aspects of the reproductive cycle? All phases of the reproductive cycle can predispose women to various kind of psychiatric illnesses. Here I have enumerated them. I will just go quickly to the important ones. Please let me know when my time is up, because mental health I can just go on and you all can keep listening, but we have to wind up and lights band karache astil hall wala na. Let us start with PMS. What does PMS stand for? Problems men start. Correct? The men don't agree. Permanent male stupidity. All women agree. Punish my spouse. Now the men agree. Okay, so when woman is in the PMS phase, she punishes. In fact, I know women are in PMS phase all around the month. Okay, they're always punishing their spouse for everything. Why you should marry, you know? Why woman should marry? Because you cannot blame Modi or God for everything. You need third person to blame few things on. So you marry. Okay, now obviously if the woman of the house is having PMS, who is the worst sufferer? The husband, the children, right? PMS is characterized by a pattern of emotional, behavioral and physical symptoms, minor to major mood changes, breast tenderness, bloating, headache, other premenstrual, we know that it's a spectrum of disorders from the physical to the emotional to the mental, crying spells, lack of concentration many women complain of. 75% of women with regular menstrual cycles experience PMS. Now this is important. PMS is caused by the progesterone that is secreted in the later half of the menstrual cycle. Now this is something you can't change and you can't halt it for a long time. You can give it some temporary relief, but the progesterone will keep coming, especially in the childbearing age. So can you imagine the distress of that woman? Month after month she has to face this without any respite till she attains menopause, after which the menopausal psychiatric symptoms will start. So there is no respite, right? Majority of women do not require medical treatment, luckily, or even psychiatric intervention, just conservative treatment like lifestyle changes, like diet, exercise. Some supportive therapy will usually do the trick. Symptoms already I have mentioned. There will be the physical symptoms, abdominal cramps, bloating, breast tenderness. Some of them get lower limb swelling. Some of them get constipation premenstrually, then they followed by diarrhea because the prostaglandins come in. So these can be the physical changes. Now there is a terminology which is premenstrual dysphoric disorder. This is something which it is detrimental to her routine life. It will seriously interfere with her day-to-day activities. And this is something that needs to be taken care of, but of course by the right kind of doctors. Extremely distressing emotional and behavioral symptoms. It is a small age group of women, but then these women are going to really have a bad time. In fact, there are the hormonal changes in this progesterogenic phase can also exacerbate underlying other psychiatric illnesses. Suppose she is already having some kind of psychiatric illness in the premenstrual phase, all those psychiatric symptoms will worsen. Generally do not respond to conservative treatment and they do need medications, maybe psychiatric help, maybe the gynecologist can help by giving some oral contraceptives and suppressing the endogenous hormones. Premenstrual exacerbation, I already mentioned, usually the psychiatric illnesses will increase in the premenstrual phase. Let's move to the pregnancy phase, okay? Pregnancy is actually supposed to be such a happy time. You're welcoming a new member in the family and everybody is excited, right? From your parents, your in-laws and your spouse, everybody is so very happy. And can you imagine the sad state when some kind of psychiatric illness haunts the poor lady during pregnancy? Psychiatric illnesses typically emerge during the childbearing age. So as such, she may be more prone. There have been cases where she has maybe a family history. She is not suffering from that psychiatric illness, but the first time symptom may appear when she gets pregnant. Recent data states that relapse during pregnancy with recurrent mood disorders in women who discontinue treatment. Now, discontinuing pharmacological therapy, especially in psychiatric age illnesses, is very common because usually they need treatment for life. And eventually, being human nature, they start getting bored of the treatment, often because of the side effects. You know, they cause a lot of sedation, often because of fear of social ostracization. She gets married, she doesn't want to tell her mother-in-law that she's suffering from some schizophrenia or something. So she cannot take the medicine, she will stop the medicine. And then they come to us with exacerbated symptoms, and on top of that, if she is pregnant, treatment becomes really hampered because we cannot give all the drugs. All psychotropic medicines diffuse readily across the placenta, and no psychotropic drug has been approved by the US FDA for use during pregnancy. So you can imagine the plight of the gynecologist and the psychiatrist if such a patient comes to you. Major depression, bipolar disorders, panic disorders, and obsessive compulsive disorder. These are the 4 leading disorders that can come during pregnancy. In the postpartum period, now this is again a continuation of the hormonal changes, and postpartum blues is one of the commonest psychiatric problem that women face during the postpartum phase. Most common, it's the least severe of problems, affects around 50%. Now just see the number, 50 to 80%. That means if we are like 50 women here, at least 25 to 30 of us have been through some point of time, we've been through postpartum blues. Depression. Now, postpartum blues usually with time, with some psychotherapy, it will go. Usually it is because of the anxiety of how will I cope up with the child. You know, child is keeping her awake in the night. She doesn't have enough rest. She's tired or she's having pain because of her surgery, either LSCS scar or episiotomy scar. Trust me, episiotomy is equally painful. When patients say, दुखेगा क्या operation में, बोली भैया normal delivery का भी दुखता है टाका. Right? So these factors can, worsen the postpartum blues. Postpartum depression, again, now this is something very serious, and like in my long years of practice, 20-25 years, I have seen 2 cases which was so severe, like a book picture. She cannot tolerate the child in front of her eyes. Can you imagine newborn baby, 10 days old, 8 days old baby, and mother saying, isko hatao mere aankhon ke samne. She is trying to kill that baby. She feels he is a threat, or that baby is a threat to her existence. She thinks that the baby has been sent by Satan. Tela rakshas hai. Ashe kai severe mental thoughts. They cannot keep the baby. Now imagine the flight of the family. They have to look after a woman who is gone totally bonkers, and a small baby who actually at that time needs breastfeeding, needs to bond with the mother. In fact, I have written a paper on this, an article which I have seen some references that children whose mothers have suffered from severe postpartum depression are themselves more prone to psychiatric illnesses in adulthood. And one of the main reasons for that is said to be lack of bonding in the initial phases because mother was suffering. Psychosis, again, this can be very severe. I have seen one girl, she ran away from home. The relatives had to actually go on a manhunt to search for her, and they had to bring her. She couldn't get controlled even in my nursing home. I had to transfer under psychiatric facility. Poor girl had to receive ECT because she was that bad. So these can be really scary situations for both the gynecologist, the family, and for the attending psychiatrist. Menopause, again, with its set of disorders. Here now the hormones are waning, so estrogens are gone. Already Shantanu has spoken at length about the physical disability, but also the mental disability. Not only because the hormones are waning, but also this feeling of emptiness. This is the time when most women think about retiring, or there is now a daughter-in-law, or the daughters are grown up, they are working, they are looking after the house, and then that woman feels that there is no place for me in this home, nobody needs me anymore, मला तर काहीच नाही, कोणी विचारतच नाही. She is in control for so many years, she is संसाराचं सगळं बागडोर सांभाळलेली, अचानक तिला तर वाटतं मला कोण कुत्र पण विचारत नाही. This is the time when she is also going through physical menopause, and they can be very prone to certain psychiatric problems in this phase of life. Sexual dysfunction in menopause, not only in menopause, in fact, throughout the reproductive years, and we have an aesthetic gynecologist sitting right here with us who is dealing probably day in and out with such things, and this is something in the women we really neglect. I remember yesterday sir said that equal number of men and women suffer from sexual dysfunction, but typically only the male come. The reason being, for a woman to be sexually excited and to get sexual gratification is not a must in the process of the sexual intercourse. In men it is different. If man cannot have erection, there is no sexual intercourse. But in women's case, it is not the case. So therefore, they will never come up with it. Women are never taught that they have a right to have sexual gratification, that they have every right to feel sexually aroused and reach a climax. So these things are never discussed by women. And this is again one more most important, in fact, I would say, part of mental health. Many marital discords will start from here. आमचं बोलणं होत नाही, त्याला काही पडलेलीच नसते, त्याचं झालं का तो उठून जातो. Men typically they'll finish and they'll just scoot, or they'll just turn on their side and go to bed. The women have some different set of requirements. I guess communication is what will help. Depression, again, women are at a greater risk, and especially in the reproductive age group, we've already spoken about the hormonal factors that can be a cause. Depression is something which not many people also, realize that they are depressed. So I guess any patient who comes to you, even from their body language, if you feel that she is depressed, you can ask few leading questions. Sorry? Oh, you're talking to him. Okay. Yeah. He was bursting balloons there. And by now, I am sure all of you also want to go do that. So I'll just take 2 minutes more. So, hormonal imbalance. So ask leading questions. Like, do you get bad dreams? Do you sleep well? Do you wake up in the night with panic attacks, or do you keep this feeling of impending doom? कधी कधी त्यांना सांगता येत नाही काय होतंय. मग you ask 2-3 questions की असं वाटतं का की आता जगूया नको, किंवा असं वाटतं का उद्या नक्की काहीतरी वाईट होणार आहे. So all these things are part of the depression symptoms. So this is something which maybe we can ask for some leading questions. Schizophrenia, bipolar disorders, these are usually very severe. They come directly with the symptoms and they go directly, I guess, to the doctors. Luckily now the stigma of going to a psychiatrist is much less. In fact, my daughter is now doing child psychiatry, and even autism spectrum is on the rise. Not only numbers are on the rise, but the orientation of parents is on the rise. What was once thought as हे मुलाचं लक्षच नसतं किंवा जरा जास्तच मस्तीखोर आहे किंवा मेंटली थोडासा कमी आहे. Now people realize these are learning disabilities. So more and more children are getting diagnosed. Anxiety, again, more amongst women. I've already put some symptoms. Anxiety and depression usually go hand in hand. The symptoms that I have spoken about. Ask them about their food habits also. Are they eating too much, or are they eating too less? Are they eating between meals, or eating, sometimes they don't know this is a psychiatric disorder. In the middle of the night, they get up and they feel that urge to eat. That is just त्यांच्या माइंड मधलं जे एम्प्टीनेस आहे ते कसं तरी भरून काढायचं असतं त्यांना. And then usually at night there's nothing much to do if your husband is asleep. So then you start binge eating. OCD is again common in women, but I guess out of the scope of this lecture. What can we do for PMS or any other psychiatric illness? We as primary doctors, can we suggest some things? Yes, there are some do's, there are some don'ts. Ask them to take calcium supplements, vitamin D, take B complex, take lots of proteins. What should not they be doing? No alcohol, no caffeine, especially at bedtime. Sometimes, we do the American way. After dinner, we have some black coffee. And that is going to send your sleep for a toss. So tell them to avoid coffee at bedtime. Nicotine, smoking, and, should be avoided. Promotion of mental health. Let me go directly to the conclusion slide. That mood and anxiety disorders disproportionately affect women of the reproductive age. Times of hormonal change may be are particularly they are vulnerable at such times, like adolescence, like during premenstrual phase, like during pregnancy, like during menopause. Treatment of psychiatric illnesses complicated by potential pregnancy. Risk and benefit of both treatment and non-treatment needs to be carefully considered and discussed with the patient and her relatives. It is essential to recognize how the socio-cultural, economic, legal and infrastructural factors affect women's health and pay due attention to it. Early and appropriate psychopharmacological intervention along with above determinants that, all these, studying her family background, studying her economic status, studying what she does in life, all this must be, taken in the right context. And overall objective is to give an effective prevention and promotion of women's mental health. Treat them on time, diagnose on time. As practitioners, it's our duty to do so. I began with a shairi. This poem is definitely not mine, but this is given to be by my daughter. So, it's a lovely poem. तो मैं पढ़ के आपसे विदा लूँगी कि मौन हूँ, निशब्द नहीं, आवाज़ है, बस बोलती नहीं, जज्बात है, मुँह खोलती नहीं, चाहत है, किसी से उम्मीद नहीं, पहल न करूँ, किसी से डरती नहीं, जीत की चाह नहीं, पर हार मानती नहीं, आईना हूँ, बिखरती नहीं, दर्द से भरी हूँ, मगर जीना छोड़ती नहीं. Thank you so much. You've been a lovely audience. Thank you for waiting till the end. And if you want some mood swings, you can definitely have them. They are available at home with your wives, daughters, mothers. Thank you women. Thank you gentlemen for bearing with us. And thank you chairpersons.
Thank you, Supriya ma'am. Thank you, Supriya ma'am, for putting some light on most neglected part in women's health. And I would like to ask Manisha Kadam ma'am to felicitate our guest speaker. And very thank you to all chairpersons who were so much into the all. Thank you all chairpersons for giving every enthusiastic ear to all lectures. And I would like to ask our WDW head, Dr. Revati ma'am, to felicitate all chairpersons. Dr. Vivek Gujar sir. Dr. Savita Gujar ma'am. Dr. Mansi Namda ma'am. And Dr. Manisha Shinde ma'am. Now I would like to hand over my mic to Dr. Nitin Rane sir for valedictory function.
So as we come to the conclusion of this wonderful event, I would like to thank many members, but to mention some of them, I hope so I don't miss anyone. First, we would like to thank the central and the state IMA dignitaries who are present today for the function, making it an elite one. Second would be, first, the venue itself, the Hotel Grand Victoria Fern, which has provided this wonderful venue. And we enjoyed the venue a lot. We know the stay was comfortable, the food was good, all the arrangements, the hall. Obviously, there were some glitches, but we overcome those, and the function went on very good. We would like to thank the online YouTube support person for giving us wonderful support and providing us the link and giving the glimpse of the conference to the online attendees as well. Also, the sound system guy who helped us with presenting all the different technical support as well as system sound support in it. IMA helpers Abhijit and Siddhant, who have provided with multiple supports over here. And we would also thank the MOCs who were present: Suraj Mahadik, Sunil Narute, Tejaswita Raut, Dr. Trupti Sid, Nikhil Ekatpure, Gayatri Ekatpure, Mansi Devdikar, Srikant Devdikar. Also, we know that this whole conference wouldn't have been such a success without all the faculties that were present over here. And they have delivered such wonderful talks on a topic which is not routine. And we know that these things are going to be there, the crux of the future. And we know all these things are going to go in a big way. So, presenting these topics is not as such a simple thing, and we have been educated in a very wonderful way about this our conference of robotics and the aptly said GENEXT conference. The next, I would like to thank all the office bearers who participated in this event and have helped in much better way as compared to what we were expecting. But obviously, Dr. Santosh Khartare sir, immediate past president, he was there for each and every step. Dr. Sanjay Sith, President, Dr. Nikhil Misa, Treasurer, Dr. Aniket Inamdar, Joint Secretary, who has given us a lot of joints, and Dr. Amol Shinde, Cultural Secretary, Rohit Fade, Sports Secretary, Digvijay Raut, Young Doctors Wing, Pradnya Gandhi, AMS Chapter Chairman, Dr. Supriya Khartare, Vice Chairman, AMS Chapter, Padmaja Fade, Secretary, IMS Chapter, also Dr. Mansi Inamdar, Monica Misa, Priyanka Mahadik, who are executive members of our body, Dr. Smita Dhotri, Gaochale in charge, Dr. Prashant Gandhi, Dr. Dattatreya Sarje, VPs, Vice President, Aditi Thite, the Clinical Secretary, Chaitanya Teke, Sports Secretary, Dr. Sujit Gandhi, Organ Donation in charge, Kiran Fade, Executive Member. Obviously, this conference was held under the Women's Wing, and Dr. Savita Gujar Madam has also helped in this. And obviously, last but least, Dr. Revati Rane, she is the organizing chairman of this EVECON 2024. Chairman WDW IMAMS, under whose idea and whose theme of this robotics and whatever we have seen, the lasers have come to light, and we have seen everything about the conference over here. So thank you all for all the IMA members, all the delegates who have attended the conference, online as well as offline, and thank you very much. We conclude the session. I would request all the IMA members of body to be on the stage and have a group photo. I would request Khartare sir to please be on stage to felicitate a few of our members. Khartare sir, please be on stage, sir. Yes. I would request Khartare sir to please felicitate our YouTube support person. Yaki. Yere. Sport. Sound system, please. सिद्धांत करायचं तुम्हीच करायचं थोरात all the office bearers who are present over here, please be on stage. We'll take a group photo.
Most of the MOCs are being felicitated already, but I would like to point that Nikhil and Gayatri had taken, not being in the IMA body also, they had taken a lot of efforts and they have been here for 2 days. Atal is almost. So they have been here for 2 days and they have shown initiative to learn, and this is really that is what we need, the youngsters coming up and trying to learn. So I would like to request, So please, Secretary, Honorary Secretary Nitin Rane to please felicitate the chairperson. Pude Nikhil, Gayatri, tumi. And also Monica and Priyanka for chairing the tumcha doginche rahilla hai. So for chairing the session, they waited till I feel that that was a very important session that you conducted. So. I request Suraj Mahadik sir to please come on stage and for being MOC and we expect such active participation in ongoing IMA programs. Monica and Priyanka, they did really wonderful job for cultural program, and I all your guidance. Yeah, sorry if I shouted in between, and but I feel our conference was you are the backbone for W. But our conference was success. The cultural program was a big event.
I request Dr. Rajiv Rane sir, please come on the stage. Sir, please. Madam, sir, Nitin sir, madam से felicitation कराएंगे. Amul Shinde sir.